Hi everyone, so my name's Amber. I'm a genetic counselor and I'm glad that you have joined us on your Saturday morning for the Texas Society of Genetic Counselors Hereditary Cancer Patient Conference. Just a few housekeeping items. So the first thing is that all of you should have been muted upon entry. And so we just ask that you stay muted for the main session talks, which means that there should be essentially like a red X through your microphone. And this is just as a courtesy to all of our other attendees and to our speakers. You'll also notice that there is the option to have a video. However, it may be best to keep videos off just to ensure that we don't have any issues with bandwidth. You'll also notice on the Zoom taskbar that there is a chat function. This can be used to send private messages to the host or co-host. When we start the main session talks, we will be having Q&A with some of our main speakers. We request that you choose Kelsey Moriarty to send your questions to, as she will be monitoring the chat function and asking those questions to our presenters. One other very important item. So on the participant list, your screen name should be at the top of your list. If you hover over your name and you hit more, you can choose to rename yourself. Now, in order to assign you to the correct breakout rooms, which will be occurring towards the end of today's conference, you must rename yourself to your first and last name so that we are able to assign you to the correct breakout room based on your registration. If you don't have your first and last name currently listed as your screen name, we ask you to change that. That way we can make sure you make it to the correct breakout room. Those gene breakout sessions will be occurring at 12:20. And again, you are assigned to the gene-specific breakout room based on your registration. Once the breakout rooms have been started, there'll be a pop-up that asks you to join your breakout session, and then it may take a few moments for you to enter that room. If you do not enter a room, it means that I was unable to assign you to a breakout room, and I'll work through the chat function to try and get you assigned to the correct room at that point in time. Also, just as a heads up, after the conference, you will be receiving an email with a link to complete a feedback survey. We will also be putting this link into the chat function. And if you wish to, you can open up the survey and you can start filling it out as we go through the presentations. And your feedback is greatly appreciated. After you complete the survey, you will have the option to enter your email address. It will not be linked to your responses, but you'll have a chance to win one of 14 electronic gift cards from places like Amazon and Target. This survey will close 1 week after, and then winners will be emailed an electronic gift card. And I just want to go back 1 second because I think I missed one of my slides. And I just want to say a huge thank you to our 3 gold sponsors, Ambry Genetics, Myriad, and Invitae. Without these sponsorships, this conference would not be possible. So again, a huge thank you to our sponsors. And then just as a reminder, this here is the agenda for today's conference. We're going to have speakers on cancer genetics, pre-implantation genetic testing, colon, pancreatic, breast cancer, prostate cancer, and then we'll move to our gene-specific panel discussion. As we do have a lot of speakers on today's conference, please bear with us as we get those speakers set up and switch between our different speakers. We hope you enjoy today's conference. Thank you.
Hi, everyone. My name's Kelsey Moriarty, and I'll go ahead and introduce one of our first speakers, but I'm also the person that you can go ahead and send your chats to or questions to, and we'll try to get do our best to get to those questions at the end of each presentation. So our first speaker today is going to be speaking on cancer genetics, and her name is Megan Honig. She's a certified genetic counselor from Baylor College of Medicine and Harris Health Systems in Houston, Texas. Her clinical interests include hereditary cancer syndromes and somatic genetic testing. She also has interests in public health, access to genetic services, and test utilization management. Megan completed her genetic counseling training at the University of Pittsburgh, where she also received her master's in public health genetics. When she's not working, Megan enjoys playing board games and spending time with her 2 dogs. Great things for quarantine for sure, Megan. And whenever you're ready, I see you're already presenting, so and take it away.
Okay, great. Thank you guys so much for having me, and thank you all for joining me on Zoom this Saturday morning. This is a very exciting conference and there's a great lineup. So I'm happy to get the ball rolling and talk about cancer genetics. Let's see, there we go. So I understand that many of you have met with a genetic counselor or already have this hereditary cancer syndrome diagnosis. So I will review some concepts that may be familiar to you, including a review of genetics and inheritance, or how this cancer syndrome can pass on through the family, along with how hereditary cancer syndromes are involved in the development of cancer. And then I'll talk about something that may be more new to you, and that's somatic genetic testing, or testing of the cancer itself. And I know that many of you have already met with a genetic counselor and have a follow-up with your specialists. As a disclaimer, I will be speaking in generalizations. However, if there's a specific thing that I mentioned that is completely different from what your medical provider has told you, please follow up with them. So as a review, we have about 20,000 different genes in our body. These genes are packaged into structures called chromosomes, and these are in our cells all throughout our body. These genes provide instructions or a recipe for proteins, and these proteins have a specific role within our body. If there is a difference or a mutation in a gene, it will cause the protein to not work properly. There are many different words that a person may use to describe this change, including pathogenic variant, mutation, or genetic change. But essentially it means that the recipe in the gene doesn't read the same way, and it causes the protein to not work properly. What that means in terms of hereditary cancer syndromes is that we know that generally speaking, these proteins protect our body from developing cancer. So if it's not able to work properly, it would cause that individual, like yourself, to have a hereditary cancer syndrome, meaning there's an increased chance compared to the average person to develop cancer over that person's lifetime. And when we think about hereditary cancer syndromes, there are certain things that we might see in that individual or in the family. Things like multiple generations of the family having cancer. It can be same or related cancers, and you might see things like grandma, mom, uncle, and yourself with these cancers. You also might see an individual who has had multiple cancer diagnoses. Not necessarily that the cancer spread from one site to another, but it started in 2 different areas, or called 2 different primaries. Additionally, we may see that these cancers in the family happen younger than we might expect, and they could be cancers that are rare or uncommon. If you met with a genetic counselor, you may recall that they drew out your family tree, and this is the things that we were looking for whenever they did that genetic testing and drew out your family tree. I keep on mentioning the word hereditary in the hereditary cancer syndrome. And hereditary means that it can be passed on through families. The majority of these cancer syndromes are what we call autosomal dominant. Autosomal means that the sex does not matter. So it can come from mom or it can come from dad. It also means that it can be passed on to sons or daughters. Dominant means that there's a 50% chance, or 1 in 2, that siblings and children of the person with the hereditary cancer syndrome would also inherit that syndrome. Conversely, that means that 1 in 2, or about 1/2 of the siblings and children would not inherit that. That would mean that more likely than not, these individuals would have the cancer risk of an average person compared to the elevated risk in individuals with a hereditary cancer syndrome. We also know that some cancer syndromes may be what we call autosomal recessive. However, because this is the minority of cancer syndromes, the majority were that autosomal dominant that I just talked about, I'll briefly review what recessive inheritance means. More often than not, individuals who have this hereditary cancer syndrome don't necessarily have parents who have that same cancer syndrome, and their siblings may or may not have it. It's not as common. However, there may be some specific recommendations that we have for individuals who we call a carrier, where they have one pathogenic variant, but the other copy of the gene works just fine. And now that I've explained how this can run through families, I want to review if your family member should be tested. I think that this is a conversation that's always a good point coming up around the holidays, though I hope you all have a safe, COVID-safe holidays coming up. But generally speaking, with individuals in your family, it's up to them on whether or not they want to undergo that genetic testing that you did. They can choose not to, and then they might still do that surveillance that you do associated with your diagnosis. However, if they do decide to do genetic testing, I would encourage it to be ordered by a doctor or a genetic counselor. You may be able to Google and see that you can order some genetic testing online, and this is what we call direct-to-consumer testing. However, I would dissuade against that. The reason being is that those tests only look for a couple of different genetic changes. They might not look at the specific change or pathogenic variant that was found in you. If it's ordered by a doctor or a genetic counselor, they'll be able to make sure that the testing for your family member is the most appropriate for them. Additionally, if you met with a genetic counselor, they may be able to provide a family letter to help coordinate this testing in your family member. And if your relative is unsure where to get started on how to find a genetic counselor or how to find an individual who can order their testing, there's a website from the National Society of Genetic Counselors called Find a Genetic Counselor. And this is something that they can Google to find that website. Now that I've reviewed how these cancer syndromes can pass down through families, I want to also talk about how having this hereditary cancer syndrome can increase a person's chance of developing cancer. As I mentioned earlier, the role of these genes is to protect us from getting cancer. Similar to how the wheels on a car help it to drive smoothly and not crash. And for the sake of this argument and these pictures, this car has 2 wheels, not 4. In an individual with a hereditary cancer syndrome, one of their wheels doesn't work, but the front wheel still works and they don't develop cancer yet. This is what we would see in hereditary cancer syndromes, where one of the genes has that pathogenic variant. However, they don't have cancer yet from the get-go with this. Instead, we know as a person ages, they may develop other pathogenic variants or mutations throughout their life. What that would mean for the car is that the other wheel, the backup wheel, doesn't work anymore, and that would cause the car to crash or for cancer to develop in that individual. This concept is called the 2-hit hypothesis. And let's say, for instance, you do develop cancer. I'm saying if, not guaranteed, but if you do happen to develop cancer, they might actually recommend doing more genetic testing. You might wonder why they would do that, since you already know that you have that hereditary cancer syndrome, that one wheel is already not working. The reason being is that in cancer, we know that there are other pathogenic variants, such as that front wheel, that don't work, that would be specific to where the cancer is. These genetic changes are not passed down, but are associated with that cancer. This testing that I'm talking about is called somatic genetic testing. In somatic genetic testing, it would be genetic testing of the cancer itself. And this can be performed on either the tumor or the cancer, or what's called a liquid biopsy. This liquid biopsy would most likely be a blood draw that's able to tell information about the cancer characteristics. And this information of understanding the cancer's genetic makeup can be used to inform cancer treatment, meaning they might have targeted therapies or specific recommendations based off of understanding the cancer's makeup. Looking at this in one other point of view, we know that instead of that car analogy where it showed those 2 genetic changes, more often than not, there's a lot of different genetic changes. And if you were to develop cancer, we would know that more likely than not, that first genetic change would be related to your hereditary cancer syndrome. We already know that information. But the oncologist might want to understand the other genetic makeup of the cancer. For instance, maybe this 3rd mutation here would have a targeted therapy, and they would be able to recommend specific treatment for you based off of that information. So that is why your oncologist, if you were to develop cancer, might recommend further genetic testing for you. Now, that was a very, very, very brief overview of cancer genetics, but I'd be happy to see what questions you all sent to Kelsey. Just as a reminder, send your chats to Kelsey, and I'd be happy to answer those questions.
Yes, Megan, we don't have any questions that have come in yet, but feel free definitely to either chat with everyone if you're comfortable or chat to me directly with questions. or if you want to unmute yourself, feel free to do that as well. Oh, I do have one question that just came in. It asks, can you do somatic testing proactively before cancer?
Oh, that's a really good question. So no, that is not something that would generally be done. The principle of doing the somatic genetic testing would be to look at the cancer specifically. Instead, the proactive things that you can do with your hereditary cancer syndrome is make sure that you're up to date on your surveillance, whether that's MRIs, colonoscopies, whatever your doctor recommends, and just be aware of symptoms of cancer. That way you can report it to your doctor.
Great, thank you, Megan. And we have a few more questions coming in now. Is there a difference between therapy for the cancer itself and therapy for a mutation?
Ooh, that is a good question. So what we know about cancer is that it's this accumulation of all of these different genetic changes. The first of which would be your hereditary cancer syndrome, along with anything else that might happen over time. Now, there may be targeted therapies, like I mentioned later on, that could develop from mutations, but it's also possible for there to still be targeted therapy based off of your mutation itself. So for those of you all who have a BRCA variant, if you're to develop breast cancer, they might recommend something that's called a PARP inhibitor. And that's just a very specific example, but there are other examples for things like Lynch syndrome as well.
Great, thank you. We've got lots of good questions coming in. So Keith is asking us to just talk a little bit more about somatic genetic testing, as this area is new or seems new to him. I don't know if there's anything else you wanted to mention about somatic testing.
Yeah, you know, Keith, I'm very excited about the field of somatic genetic testing. It is, I think the next step with cancer in general. We know with these hereditary cancer syndromes, we have those recommendations for you with your surveillance. And now with somatic genetic testing, if you were to develop cancer, they may be able to identify targeted therapies. I don't want to sell it as the golden ticket, because it is also possible for them to not find anything to adjust your therapies on, though.
Alrighty, the next question we have is, do we need to repeat genetic testing after a while?
That's a really good question. And that's something that meeting with a genetic counselor specifically might be beneficial for. Generally speaking, with your, with your cancer syndrome itself, this germline testing, or this gene that could be passed on through family, more likely than not, does not need to be repeated if they have identified this hereditary cancer syndrome. But there are a handful of instances where, if there is already that diagnosis, they might recommend more testing to see if potentially you have 2 hereditary cancer syndromes. Now, if they did this type of testing looking for a genetic syndrome and they didn't find anything, and that was maybe a couple of years ago, or maybe it was a small test, that is an instant where they might recommend repeating this type of germline testing. Regarding the somatic genetic testing, this is something that, based off of your oncologist's recommendations, they might want to do a serial monitoring, kind of like how if you're to develop cancer, they'd want to do imaging every once in a while to see how the cancer is doing. They might also want to repeat this testing to see how the cancer is doing.
Thanks, Megan. The next question is it possible to have the same CHEK2 mutation but develop different cancers? For this person, the situation is that her mom passed of a different type of breast cancer than she had.
Right. So breast cancer is, or just any cancer in general, is kind of an umbrella term. We know that with breast cancer specifically, there can be different kinds of breast cancer. Is it in the duct of the breast? Is it in the lobular breast cancer? So there can be different types of breast cancer still under that umbrella. And it's possible for individuals to have different types of breast cancer still within the family, still within the umbrella. But we do also know with some cancer syndromes we might see, for instance, we might see more lobular type of breast cancer, but that would be a specific question to also follow up with your medical providers.
Alrighty, we have time for maybe 1 or 2 more questions, so I'll try to get to as many as we can. The next one is, would it be helpful to have somatic genetic testing if one has already had genetic cancers and been treated for it?
So if your cancer has already been treated and you're in remission, I just want to say congratulations, that's wonderful news. But right now, with somatic genetic testing, that's mainly used to guide treatment. And if you're done with treatment, then I would imagine they would not recommend that for you, but that might change in the future.
Perfect. Thanks, Megan. I'll go ahead and transition us to our next presenter so we stay on time. But those of you who had entered more questions into the chat, I'll try to respond to each of you with some answers to your questions as well. So without further ado, I will introduce our speaker for our presentation on pre-implantation genetic testing. So Sandra Derelek is a genetic counselor and assistant professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. She has a Master's of Science degree in genetic counseling from the University of Texas Houston Health Science Center, Graduate School of Biomedical Sciences, and received her board certification from the American Board of Genetic Counseling in 2005. Sandra is co-manager of the Prenatal Genetic Counseling Service at Baylor College of Medicine and Texas Children's Hospital, and is chief of the Baylor College of Medicine Consultagene Clinic. She specializes in providing genetic counseling for preconception, prenatal, infertility, and pre-implantation genetic testing. All right, Sandra, whenever you're ready, feel free to present your screen and go ahead.
All right, so let me go ahead and get my slides up. And as you guys can probably tell, I'm a little bit of a change of pace from what you just heard from Megan, because I work in prenatal and preconception instead of directly in cancer. But I was asked today to talk about what options are available primarily as a way to try to prevent the passing these genetic cancer syndromes through a family. So if you've already had your family, this might not be as pertinent to you, but if you've got children or grandchildren and you're dealing with a hereditary cancer syndrome in the family, this might be options for them to be aware of. So I have no disclosures. I work for Baylor College of Medicine. I work in the Department of Molecular and Human Genetics, and I also work with TCH. So what is pre-implantation genetic testing? Well, pre-implantation genetic testing, or what we refer to as PGT, is an option that's available to try to reduce the risk for a genetic disorder in a pregnancy. And we reduce that risk by doing a few things. One, using a procedure called in vitro fertilization, or IVF, to obtain embryos prior to them being in a woman's uterus, and then testing those embryos for the genetic condition, or in this case, the hereditary cancer syndrome that we're concerned about. And then once we've tested those embryos, we have the ability to sort through them, and based off of those test results, choose embryos that are not expected to have that hereditary cancer syndrome and use those for transfer in hopes of a pregnancy. PGT has several requirements. Like with a lot of things in medicine, it's a process. So the first requirement is that you have to use in vitro fertilization. And then along with that, there is testing setup that's done. This is a very specialized, a very targeted test, and it's a test that's actually designed on a family by family basis. There's actually biopsy of the embryo itself so that we can get cells that we can do testing on to figure out the embryo's status. It requires freezing or cryopreservation of embryos so that they remain available or viable until we have test results. And then there's the actual genetic testing of the embryos, of those cells that we biopsied, so that we can figure out what the actual status is of each embryo that we've obtained. Since IVF is a big part of this, I think it helps to understand a little bit about what the process of IVF looks like. So for people who are not familiar with IVF, IVF is a way for us to help people get pregnant by obtaining eggs from the woman, sperm from the partner, and then fertilizing those eggs with those sperm and allowing those embryos to grow in the lab. So the basic steps of IVF start with something called ovarian stimulation. This is a period of time of about 2 weeks where the woman who's undergoing IVF is on daily medications so that her ovaries are producing multiple eggs that would be available to be fertilized at one time instead of the typical 1 egg that we get from each of our cycles. After that, we do something called egg retrieval, where they actually, in a way, biopsy the ovaries so that they can get every egg that was matured during that cycle, every egg that's available for fertilization. After we've retrieved those eggs, they are then fertilized and allowed to grow in the lab, typically for about 5 or 6 days. So we get those eggs, they're assessed, they're fertilized with sperm, and then for 5 or 6 days, they're growing in the lab. And then there's a testing process, which I'll go through. But then the end result of IVF is something called embryo transfer, where after we know everything that we need to know about the embryos, we select an embryo for transfer, and then that embryo is placed in the woman's uterus in hopes of getting a good, healthy, ongoing pregnancy. The second big part of this is the actual testing process. So with PGT, you've got IVF, which is what gives you the embryos for testing. And then you've got the actual testing process that gives you the genetic test results that you're interested in. So with the testing process, we first have a test setup phase where a very specialized lab will design a test on a family-specific basis. Again, as part of the IVF process, they'll do an embryo biopsy to get the cells for testing and then freeze those embryos until we have test results. And then we'll test those cells so that we know each embryo's status. The testing process from the actual start of the analysis, or the actual meat and potatoes of the testing process, starts with the embryo biopsy. And this is typically done about 5 to 6 days after the eggs were fertilized. And on that day, embryos typically look like this, what you see off to the right. And at this point in time, embryos have 2 sections. They've got a group of cells that sit off to one side, and these are the cells that will ultimately become the baby during a pregnancy. And then around the edge, you've got these cells that ultimately become the placenta during the pregnancy. And when we do this testing, when we do these biopsies, we're taking about 5 to 10 cells from that outer edge of the embryo for testing. Once we've gotten those 5 to 10 cells, the embryos are frozen until we have the test results and select which embryo we want to use for a transfer. Prior to all of this, prior to the embryo biopsy, prior to the IVF, there's actually a test setup process. And in a way, this is one of the most important parts of PGT, because if you're going to go through everything required for PGT, go through IVF, go through embryo testing, you want to know that you're getting a test that's highly accurate, that gives us very good, very reliable test results. And so the test setup piece of this is what allows for that. So prior to starting IVF, you'll actually be put in contact with a lab that's doing the testing for you. And they're going to design a test specifically for your family's genetic situation. They need several things. First, they need copies of genetic test results. So PGT is available for cancers that are related to hereditary cancer syndrome. So if there is an inherited cancer syndrome in the family, then this is an option. And we need to have a copy of those genetic test results so we know what genetic change we are concerned about, which genetic change is running through the family. Then we also typically need a DNA sample, either a blood sample, a saliva sample, or just a straight DNA sample from the couple that's undergoing the IVF, and then also often from other family members. And I'll explain why that is in just a minute. And then we need time. So a lot of people that I talk to who are interested in this option, in IVF and embryo testing, think it's a very quick process that we can decide to do this, and then next week or in a couple weeks we'll be in the middle of doing this. And that's not the case. Both IVF and the embryo testing takes time, and the test setup actually takes several weeks. And so on the front end of this process, we have to plan that there's going to be several weeks worth of time where the lab needs to have that time to set up the testing for us. I'm going to walk you through a little bit about how the testing works, because often a question I get when I start talking about the testing process with families that I work with is, why does this take so long to do the test setup? And then also, why do you need other members of my family, like my parents, or maybe a DNA sample from one of my siblings to do this testing? And the biggest reason for that is that embryo testing is very different from almost every other genetic test that we do. Most of the time when we do genetic testing, we've got a lot of DNA to work with. So for example, if you've had testing for hereditary cancer syndrome, typically they did that off of a blood sample. And in that blood sample, there were hundreds and hundreds of cells and lots of DNA that they got to work with. And when we do genetic testing, we typically don't rely on one result. When they do your genetic testing, the lab typically runs that test, gets a result, and then runs it again to confirm that result, to make sure that they are seeing the same thing more than once, and they can be confident that what they're seeing is actually there and the correct result. Well, you want that same type of accuracy, that same type of confidence when you're testing embryos. But the limitation is we only have 5 to 10 cells, and that's not a lot of DNA to work with. And it's not really enough to give us the ability to run a test and then run it a second time. So what labs actually do to increase the accuracy, to increase the confidence of these test results, is they build a test that has a second check, a double check, a confirmation built into it. And that's where needing family members comes in. So let's say, for example, I have a hereditary cancer syndrome. I have a BRCA1 variant, and I've decided that I am interested in IVF with PGT to try to prevent passing this variation on to my children. Well, what the lab will first do is ask for a DNA sample from me. And what they'll do is confirm first that they can see that variant in my DNA. And then what they'll also do is look for what we call DNA markers. So all of us, in addition to having all of our genes, have DNA markers around every gene that we have. And these are the types of markers that are specific to us and our families. These are the types of markers they use for other types of genetic testing, like forensics, in solving crimes, or in paternity testing. And what these markers do is they allow us to actually track genetic changes through a family. So a lab will get a sample from me, They'll know that they can find my genetic change, and then they'll also find out what marker patterns go with my BRCA1 gene. Since I have two, I'll have two marker patterns, one that I got from my mom and one that I got from my dad. The trouble is that with my DNA alone, what I don't know is whether this ABCD pattern that I got from one of my parents goes along with my BRCA1 variation, or if that 2478 marker pattern goes along with the variation that we're worried about. And so in my family, if my father was the parent that I inherited that BRCA1 variant from, the lab would ask for a DNA sample from him. And then what they would do is look and see, what do we have in common? Well, what we know is that I have a BRCA1 variant and he has a BRCA1 variant. And what we also know from this testing is that we also have this 2478 pattern in common. And so what that tells the lab is that 2478 pattern is what is traveling with the BRCA1 mutation in my family. So they use that information along with the information from my partner. So they're also going to want to know what his marker pattern is. And they'll put all of that information together to figure out what the status of our embryos look like. So any embryo that we would get that gets that ABDF pattern that I have, the one that is not traveling with the BRCA1 variant, we know those embryos would not be expected to get that variant from me and should not be at increased risk for this hereditary cancer syndrome. So those would be the embryos that we would feel comfortable working with. Any embryo that got that 2478 pattern, we would know would have it, they inherited that BRCA1 variant from me, and then they would be at risk for the same cancer risks that I have. This last example is where the importance of this process with these markers comes in. Sometimes you'll get what's called an indeterminate result. So in the past, when we first started doing embryo testing over 30 years ago, they actually used to only look for the presence or absence of a variation. And what we realized is that sometimes the labs got it wrong. Sometimes they would get a sample, they would test it, and they wouldn't see the DNA variant in the embryo, and we would assume that it didn't have that genetic change. And then later on, either during testing during pregnancy or testing after birth, we sometimes would find out that the child still actually had the variant. And what we realized is that sometimes when you're dealing with small amounts of DNA, one copy of the gene won't show up in the testing. It'll do what we call drop out of the testing. And that can lead us to get incorrect results. So what this approach, looking at these marker patterns, does is it does two things. One, it tells us, does the embryo have the marker pattern that's traveling with the variation in my family, or does it not? And also, in the testing, did we actually see two copies of the gene, one from me and one from my partner? If, for example, we only saw one copy of a marker pattern, and that marker pattern came from my partner and not from me, then what the lab would know is that they don't know what the status of the embryo is for my mutation, that we don't have all the information. So this prevents us from having what we call a false negative result, a result where we think everything's okay and we don't actually have all the information. What this whole process allows for is the labs that do this testing to have 98% accuracy or 98% confidence in their test results. You never get 100% with medicine, and you never get 100% with genetics, but 98% confidence is pretty good when you're dealing with a genetic test. A question I often get from people that I'm talking about is, so how long does all of this take? You keep saying it's a process and that there's time involved. So exactly how long does this take if I want to do, or if my child, if my daughter is interested in IVF or my granddaughter, how long does this take? Well, the PGT setup, the test setup itself takes about 4 to 8 weeks. In addition to that, you'll also be working with an IVF doctor, and there's going to be some initial evaluation on that end as well. And so that evaluation by the IVF doctor also takes about 4 to 8 weeks. Those two things can be done at the same time. What we also then have is once we're ready to start, there's about 3 to 4 weeks of time where a woman's put on birth control prior to starting IVF, which sounds kind of counterintuitive, but IVF is about control of a cycle, and that allows the doctors to have control over when everything starts. Then there's 2 weeks of medication to push the ovaries to produce those eggs. About a week from the time that we retrieve those eggs till the time we biopsy them and then freeze the embryos. About 1 to 2 weeks to get actual test results from the testing of the biopsied cells. And then once we have test results, most doctors will wait about 4 to 8 weeks before they actually transfer an embryo so that they have some time to prepare the woman's uterus to receive that embryo in hopes for a pregnancy. So overall, the time is about 15 to 25 weeks, about 4 to 6 months from start to finish. Now, there's a number of things people need to know and need to think about before they decide if IVF and embryo testing is right for them, because it is not the right option for everyone. First, what do you need to know? Well, you need to know that this can be performed for most hereditary cancer syndromes, as long as we know what the genetic variation in the family is, as long as genetic testing has been performed and we found a genetic change that we think is causing that hereditary cancer syndrome. Again, the testing requires setup, and that requires several weeks for that setup. And then typically labs will need a DNA sample from another family member from your family who has that same variant. Now, if that's not the case in your family, if you're the only person in the family who has tested positive for a variant, or if, say, the parent that you have that also had the cancer variation has passed away, there are still ways in some cases to do this testing. It's a little bit more complicated, but still often possible. What do you need to think about? Well, first and foremost, IVF and PGT does not guarantee a pregnancy. Just because you go through this whole process doesn't mean that it will necessarily be successful and lead to a pregnancy. This also doesn't eliminate risk. We always talk about reducing risk, and we are reducing risk by about 98%, but we're never confident that we've completely eliminated this risk. There are reasons why a test result could be wrong. So we still recommend testing either during pregnancy or after the baby's born or later in life to confirm those test results were correct. This doesn't test for all genetic conditions. So if you choose to do IVF and embryo testing, it's a very targeted test. You're testing for that one hereditary cancer syndrome. You're not testing for every genetic condition at the same time or other types of cancers that may not be related to that hereditary cancer syndrome. You also have to think about whether you're comfortable with the IVF process and the embryo testing process and the costs that go along with that. Financial costs, the physical and the psychological aspects of that. You need to think about whether you're actually comfortable creating and testing embryos. For some people, this is a non-starter. This is something they're not comfortable with, or their belief system does not agree with this approach. And for them, IVF is not an option. You have to think about what you're going to do with embryos that test positive for that familial variant that are expected to be at increased risk for cancer. And you have to think about whether you're actually comfortable discarding those embryos or what you're going to do with them. You need to think about what you're going to do if you have no embryos that are negative for that genetic change. What happens if every embryo actually tests positive for that? And you need to think about what you're going to do with any extra embryos you have. Some people will go through IVF knowing that they want to have 2 children and that's what they can afford and that's what their family can handle. And sometimes they'll get 4 embryos. So what happens with those extra embryos once you've completed the family that you wanted to have? Other considerations are cost. So I often get asked, what's the approximate cost for IVF and embryo testing? Well, IVF cycles usually run somewhere between $10,000 and $15,000, with medications costing about $3,000 to $5,000. The embryo testing itself, from test setup to testing, costs somewhere in the range of $3,000 to $10,000, depending on the complexity of the testing and the number of embryos tested. And then when you freeze embryos and store them, the cryopreservation, that costs about $500 each year that those embryos are being stored. Costs vary from clinic to clinic, and insurance coverage varies widely, both between different insurances and also often between insurance plans within the same insurance company. So often we need to figure that out on a patient-by-patient scenario. There are financial assistance options, both grants and loans out there. And so I provided this slide for anybody who's interested in this option but wants to know about financial assistance. All of these websites provide different links to different opportunities, some that are cancer specific and some that are more general. I also briefly wanted to touch on the fact that there are other options out there. So first and foremost, anybody who is of reproductive age, who's been diagnosed with cancer, even if it's not a hereditary cancer syndrome, if you're still planning to have a family, you may want to talk to your oncologist about your fertility preservation options, specifically if your cancer treatment might affect your fertility. And that includes things like egg and sperm banking. If you want to have a family but don't want to pass on a hereditary cancer syndrome and embryo testing isn't the route to go, sometimes you can consider things like using donor eggs or donor sperm to take that genetic risk off the table. And then, of course, for people that IVF is not an option for, adoption is something to be considered as a family building option. If you're interested in this, how do you find resources? Well, I always say talk to your genetic counselor, talk to your healthcare provider or your oncologist. You also could set up a consultation with a genetic counselor like me who specializes in this area to talk through the details. You also have the option of reaching out directly to IVF centers in your area to see if they offer the embryo testing, or reach out to a lab that does the testing to see what groups they work with in your area. Bottom line, as far as this option goes, PGT is an option that's available for most hereditary cancer syndromes. And so if it's something that you would want to explore, it's worthwhile to get some more information about that. It is a process and a multi-step process. It reduces, but it doesn't eliminate risk. And while it's a good option for some people, it's not necessarily the right option for everyone. And that's all I have. I'm happy to answer any questions in the time that we have remaining.
Great, thank you so much, Sandra. I do think we have a couple minutes here. One question that did come up was, does the process of ovarian stimulation pose a risk for women with a family history of hormone receptor positive breast cancer?
So that's a very good question. I always defer to both the IVF doctor and the oncologist to have a conversation about your particular cancer to see if the approach that the IVF doctor would want to use needs to be tweaked to reduce any types of risks. If we look at actual IVF data, though, even in women who have family histories of cancer, we do not see increased cancer risks because of those hormone treatments. And I've actually worked with a number of women who have either personally had breast cancer or who are BRCA1 or 2 carriers, and they have been able to safely go through IVF with a protocol that made sense between their IVF doctor and their oncologist.
Great. Another question that came in was that these tests look very expensive. How can a couple with limited funds get this to happen? And I think you answered that during your presentation with a couple great resources there.
Yeah,
any other comments?
Yeah, I think that list is a good place to start. Also, IVF groups sometimes themselves have financial assistance plans. So sometimes that can help as well. There are increasing numbers of groups that are trying to make this option available for people with hereditary cancer syndromes. And so I think that list of resources is going to continue to grow.
Okay, and just a quick comment from Keith, who says, Sandra, you're doing a great job on a touchy subject. So I think people are appreciating your presentation here.
Thank you.
And that's all the questions we have at the moment. So if anything else pops up, I'll definitely reach out to you, Sandra, but we'll go ahead and transition to our next presentation. Thank you so much.
Absolutely.
Alrighty, just as a quick reminder, please do go ahead and rename yourself in the participant list. If you hover over your name, you should be able to click more and then be able to, from there, to rename yourself to your first and last name. That's just so we can get you into the correct breakout session. I will also be trying to send you the link for the feedback form as well during in between each presentation. That way you can go there and fill it out as we go along today. And then our next presenter, Dr. Wells, has already got her first slide up there, so that's perfect. I'll give her a little introduction. Dr. Wells specializes in the management of colon and rectal cancer in those with inherited colon cancer syndromes. She also specializes in the management of the benign colon and rectal diseases. She treats patients suffering with pelvic floor dysfunction, offering a comprehensive approach to problems like constipation, incontinence, and pelvic prolapse. Dr. Wells also specializes in the care of people with inflammatory bowel disease, including ulcerative colitis and Crohn's disease. She works closely with gastroenterologists and multidisciplinary approach to create treatment plans that are customized to the patient. One of her academic interests is inherited colon and rectal cancer syndromes. The goal of her research is to increase understanding about these rare syndromes and find better ways of diagnosing and treating people at a higher risk for cancer. She and her husband and son enjoy being outdoors. They love to see and do new things, including traveling, experiencing different cultures, and meeting people from all walks of life. In her spare time, Dr. Wells enjoys cooking and being a mom. We're really excited to have you with us today, Dr. Wells, and I'll let you take it away whenever you're ready.
Thanks, Kelsey, and thank you to all of you for being here on a Saturday morning. I congratulate you for being so invested in your health. So it's a very broad topic, colon cancer in the setting of inherited syndromes. I'm also going to roll that into young onset colon cancer, which is a rising trend that we're seeing across Western countries. And they're all part and parcel, especially as we learn more about young onset and the genetic basis of those. So let's see. I can figure this one out. So just an overview, we're going to talk about the shift in colorectal cancer statistics. I'll talk about some select cancer syndromes, the screening and treatment strategies for those. We're going to go over some environmental factors that affect everyone, inherited cancer syndrome or not, for cancer development. And I'll give you some practical takeaways. So just to frame how recent all of this is, in 2018, the American Cancer Society revised their colorectal cancer screening guidelines such that the average risk person actually needs to undergo screening at the age of 45 rather than 50. And this was in response to the rising trend of colon cancer that we're seeing in young people. This can be done for average risk people with a structural exam, which I'll explain, or high sensitivity stool-based test. There are multiple task forces and associations that guide screening guidelines. The American Cancer Society is the first to make this change, and we expect that some of the other ones, including the US Multi-Society Task Force, which is the one that guides the majority of our insurance providers, will follow suit. So the options for screening, structural screening, are colonoscopy, which is an evaluation of the lining of the colon A person will come after completing a bowel prep to clear the colon of stool, receive some sedation, and then the provider will perform a endoscopic exam. So it's basically a flexible tube with a camera at the end that allows us to very closely inspect the lining of the colon, looking for things like polyps or cancer. Polyps are small growths in the lining of the colon that we believe over time will develop cancerous changes. And so when we see them, we take them out, essentially preventing cancer from happening. A flexible sigmoidoscopy is a partial colonoscopy that in the average risk person could be done every 5 years in combination with a stool test, and a CT colonography, which is an imaging study that still requires a bowel prep. The stool-based options for screening are a FIT test, which looks at the immunochemical profile, sorry for the misspelling, immunochemical profile within stool, high sensitivity GOIAC, which tests some component of blood that could be present in stool, and more recently, the multi-target stool DNA test, the Cologuard test, that in average risk individuals is done every 3 years. It's important to note that these stool-based tests are screening for something very different than what the structural exams screen for. These screening tests are looking for advanced changes, either advanced polyps or cancers within the colon. So when they come back positive, the person may undergo a structural test that may identify cancer, essentially catching the cancer really when the horse is out of the barn. So it's not a preventative screening test per se. Cologuard, many of you may have questions about, is the newest of the non-invasive screening methods. It's not recommended for people with inherited syndromes. It is an expensive test. It's about $600. It's basically testing for 3 genetic markers that are present in most cancers. And the sensitivity, so the ability for it to pick up a cancer is pretty good. It's high, it's 92%. But you'll see the sensitivity for picking up an advanced adenoma is not high. So it would miss an advanced adenoma potentially, but it would find the cancer. There are some tests in the pipeline under development that look at more specific or maybe a larger profile of genetic makeup that we would expect in a cancer or a polyp. The preliminary studies show pretty good sensitivity for picking those polyps up. So it may be that we'll have some non-invasive screening methods in future that are better or more specific for adenomas. There's no question that colon cancer screening saves lives. It's the largest single driver for decreasing colon cancer. And we saw a trend once colon cancer screening was adopted in people under 50 over the past, certainly over the past 20 years, we've seen an increase in adherence, which parallels a decrease in the rate of cancers that we're seeing in the population. And you can see here in broad strokes, colon cancer is on the decline. It's a common cancer, so we have many, many people that are diagnosed with it annually, 140,000 a year, and it's the second leading cause of death. There are some cultural and hereditary, there are some cultural groups that are at higher risk for getting cancer, but you'll see by gender, the risk is about the same, and over the last 20 to 30 years, the rate has gone way down. That's on the whole. However, if you hone in on young people, if you look at the bottom of that graph, you'll see that the rates are actually going up, such that an adult that's born in 1990 has 2 times the risk of colon cancer and 4 times the risk of rectal cancer versus an adult who's born in the 50s. We can see that people who are over 50 are seeing a 2.5% decline in the incidence rate, and people that are under 50 are seeing inversely a 2.7% increase in their cancer, in the percentage of their cancer risk. In a smaller group, young people, 20 to 29 range, the annual percent change that in the rate of cancer is actually double that. But again, it does sound alarming, but it's a doubling of the percentage of a very small number of people. But it definitely warrants watching because the rate is truly going up. The age-adjusted mortality is decreasing in those over 50 by about 2 to 3% annual percent change. And inversely, the mortality for those under 50 is going up by 2% annual percent change. So we estimate that in 2030, 11% of the people that have colon cancer are going to be young. They're going to be under 50. So that's a serious problem. We've tried to characterize the people who have cancer under the age of 50. The National Cancer Database, which is a national registry of everyone with cancer that is supplied by a number of centers that report to the Commission on Cancer, has found that they tend to be poorly differentiated, which is a higher grade sort of more irregular looking cancer than most. They have some high risk features, mucinous features, signet ring features. These are what the cells look like under the microscope. The Cleveland Clinic, when they look at their group of patients with young onset, found that there are some epigenetic changes, some genetic changes that are less common in young people. And MD Anderson, when they published their data on patients with young onset colon cancer, they found that of those that were under the age of 35, 20 to 35% of them had some genetic mutation. That's a tenfold difference than the 2 to 3% that we quote for patients over the age of 50 having a genetic syndrome. The Ohio Colorectal Cancer Prevention Initiative study group also identified a much higher rate than the older population of having a genetic mutation. About 16% of people under the age of 50 had an identified mutation. What was interesting about that group was about 30% of those people didn't have the typical clinical findings that you'd see in a syndrome, or they didn't read the textbook, so to speak, which really pushes the recommendation that when people under 50 have colon cancer, they really should undergo multi-panel testing. So that's testing for a number of genes rather than some specific things that we think it could be. For those that don't know that they could have a genetic syndrome and can start early surveillance, young people who are found to have colon cancer end up presenting in a later stage. They're usually stage 3 or 4. That's where the cancer has traveled to the lymph node or traveled to distant parts of the body like the liver and or the lungs. The diagnosis, unfortunately, happens about 6 months later than when the person becomes symptomatic. And there are a number of reasons for that. I think one of the big reasons is that young people don't think that they're at risk for cancer, and so they can neglect their health or neglect their symptoms. Many people that are young don't have adequate insurance to allow them access to a provider. And on our end, we're not attuned to thinking about cancer when we see a young person. And so about 2/3 of people with young onset colon cancer have seen between 2 and 4 physicians to address their symptom before a correct diagnosis is made. Rectal bleeding is one of the most prominent symptoms related to colon cancer, and painless rectal bleeding is associated with a 25-fold increased risk of having cancer. The bleeding actually predates the larger symptoms of colon cancer like blockage, pain, by about 2 to 3 years. So you can catch it early if you just pay attention to the symptoms. The psychosocial impact, of course, is great. These are young people with their whole lives ahead of them, with families, young children, endless potential. But instead, they have to worry about cancer. Let's talk about the non-modifiable risk factors for colon cancer. I take care of a good number of people with inflammatory bowel disease, ulcerative colitis, and Crohn's disease. The rate of that's is on the rise, especially in Western countries, and it is associated with a 2 to 3-fold risk of colon cancer. So we watch those people very carefully. The having received abdominal or pelvic radiation increases your risk later in life. And then, of course, the focus of the talk today are the familial syndromes. So there are some known mutations, of course, and many of you are in this are on this webinar because you have them or you have family members that have them. But just like everyone else, being young, not everyone has great insurance. Not everyone has access to providers that can offer the expertise to treat your syndromes. And so cancers, unfortunately, still occur despite the knowledge of having a mutation. There are some familial syndromes that are not diagnosed. There are just trends that run in families without a specific genetic test. And so if you're not attuned to what's going on in your family, you may not realize your risks and may not start early screening. There are some emerging genetic syndromes that providers are not aware of and don't know to look out for when a patient comes with symptoms or with family patterns of cancers. And we'll talk about one of those. So this is a nice schematic of the people under the age of 50 with colon cancer and how the familial patterns are distributed. And you can see in the red box about 50% of people with young onset colon cancer have some familial pattern. So again, it's important. So these people that are in the smaller box are ones that don't have a genetic syndrome identified, but definitely have some familial trend. So it's important to talk to your family members. As Megan mentioned, the holidays are coming up. Hopefully it's a COVID safe gathering that you might have, but it's a good time to talk to your family about their health. And it's important to get specific. Yes, if they've had cancers, we want to know that. But we also want to know if they've had polyps or high-risk polyps, because that increases your personal risk by twice. And then as the number of family members increases or the closeness of those family members to you increases, your risk can be up to 4+ fold more than the average population. Let's talk about Lynch syndrome. That's about 10 to 15% of all the people with young onset colon cancer. Lynch syndrome is a autosomal dominant, a genetic mutation that causes a defect in the mismatch repair complex, which is a protein that is made to fix errors in DNA that occur over time. When you have one of these mutations, your lifetime risk for all of the cancer, all of the organ systems listed on the left of the screen is elevated. And the onset of cancer is usually in your 40s for colon and endometrial cancer. And so you have to start screening earlier than the average person. You can see in the column that's just to the all the way to the right of the screen, that is the population, that is the cumulative risk of over one's lifetime for the general population. And you can see right next to it, that is the cumulative risk for diagnosis of cancer through pretty much one's lifetime for Lynch syndrome. And you can see almost every organ system is at a 10-fold increased risk for developing cancer. So once we have a person who has either a diagnosis of cancer that is tested and shows a Lynch syndrome related mutation that then ends up being in their blood test, or they have a family member who has Lynch syndrome and they themselves also get tested and are found to have Lynch syndrome, they're recommended to undergo a colonoscopy starting at the age of 20. And they're supposed to do it every 1 year. For endometrial cancer, it's a bit controversial. It is based on the physician's sense of risk and the person's willingness to undergo testing, but usually they undergo an endometrial biopsy once a year starting at the age of 30. To look at the ovaries, which are also at increased risk for cancer, we get a transvaginal ultrasound. There is a risk for cancers related to the urinary tract. And so we start annual urinalysis, which is basically a check looking for blood in the urinary tract every year, starting at the age of 35. The risk of gastric cancer is variable in people with Lynch syndrome. And so we usually get a baseline upper scope, which is to look at the stomach and the first part of the small intestine at between 35 and 40. And if that's normal and the person doesn't have a strong trend of gastric cancer, or they're not in a population that has a high rate of gastric cancer, like in Asian populations, for example, then we really don't have to do an upper scope unless they develop symptoms. For pancreatic cancer, it's fairly new that we actually do screen for that. And starting at age 50 or 10 years younger than the person in their family who is diagnosed with pancreatic cancer, we offer an MRI that looks specifically at the biliary system and the pancreas, or an EUS, which is an ultrasound-based test that's done in combination with the EGD, so looking at the stomach. There is a small risk of brain cancer, and so we do neurologic exams every year. There are some therapies that do not treat Lynch syndrome itself, but decrease the burden of polyps that Lynch syndrome patients can develop. So that's called chemoprophylaxis, basically medication that's preventative for the development of disease over time. The goal of chemoprophylaxis in Lynch syndrome is to avoid resection, which is a surgery to remove whatever organ system is affected, and to allow for endoscopic management. So if the polyp burden is low, then it's easier for us to remove them with the colonoscope. If the polyp burden becomes very, very high, and we cannot safely or easily remove all of these polyps through the colonoscopy, then the person is recommended to undergo a removal of their colon. So the goal, again, of chemoprophylaxis is to make it easier to remove polyps with the colonoscope. It may also allow us to stretch out the length of time that a person needs to undergo a colonoscopy, but right now the guidelines are really every 1 to 2 years. Aspirin is the main chemoprophylactic agent that's supported in Lynch syndrome, but we'll talk about briefly some novel therapies that are in the pipeline. The target of aspirin is to reduce I'm going to skip this slide, but the goal of aspirin is to reduce the colorectal cancer cells that develop some changes that we see in Lynch syndrome DNA. So what aspirin does is it basically causes the type of cells, the type of cancer cells that that we typically see in Lynch syndrome to die. And the effect is time dose dependent. The CAP2 study, which is a randomized control trial that compared taking basically food starch and taking aspirin in high doses, showed that the use of aspirin at a dose of 600 milligrams a day, which is double regular aspirin, for a mean of 25 months, so 2 years, reduces your cancer incidence by about half. 600 milligrams is a very big dose to tell people to take. It can really tear up your stomach, but that is the information that we have right now. And that's the information that I share with my patients who have Lynch syndrome. There's another study in the works called CAP3, which hopes to look at the optimal dosing, and hopefully it would be a little bit lower that's adequate. I'm going to skip this slide too. There are some novel approaches to Lynch syndrome that are not available currently, but just so that you're aware that there are people thinking about these very unique ways of treating Lynch syndrome cancers. One of them is an FSP vaccination. An FSP vaccination basically is a vaccine, just like any other vaccine to treat a disease, that is focused on targeting some of the proteins that are made as a result of mutations that we see in Lynch syndrome cancers. In broad strokes, the idea is to train the body to actually identify and clear the cancers that are created by Lynch syndrome. It's been tested in phase 1 and 2A trials, which basically test the safety, not necessarily how effective it is. And it is safe, and it does create antibodies, and it is something that may be in the pipeline. Gene therapy is also something that is available for some genetic syndromes. There are no gene therapies available for inherited colorectal cancer syndromes as yet, but there is some promising research that's going on for gene therapy related cancer syndromes that affect the lungs, the brain, the bladder, and the liver. The treatment of Lynch syndrome cancer is really surgical. So if a cancer is anything less than stage 4, and in some cases stage 4, it is recommended that a person with Lynch syndrome who has cancer have their whole colon removed. In an average risk person, or in a person who has a sporadic cancer, that means one that's not related to a genetic syndrome, the surgical management is to remove that portion of the colon. So usually we talk about colons in halves. There's the right colon and the left colon. And so if there is a cancer in one of those areas, we tend to take out the whole right colon in an otherwise average risk person. Or if there's a cancer in the left colon, we'll take out the left colon. For people with Lynch syndrome, their risk of developing cancer once they've had cancer, their risk of developing another cancer, which is called a metachronous cancer, it's a cancer that develops at a different point in time, is pretty high. So it's at 16% at 10 years after they have their first cancer, and it goes up to 60% up to 30 years after they've had their first cancer. And so it's really recommended that once a person has cancer, we remove the whole colon to eliminate that risk of metachronous cancer. We generally say that the risk of metachronous cancer goes down by 30% for every 10 centimeters of bowel that we remove. So it is not, it's not dogma. The decision to remove someone's whole colon is a big one, and it means some very functional changes to the person. And so when we talk about it in the office with the person, it's always a sort of a customized approach to see what makes sense with the person's overall function, their lifespan, and their ability to undergo further surveillance with colonoscopy. The medical treatment of colon cancer, that's colon cancer that is stage 3 or above. is usually a specific chemotherapy called FOLFOX. We don't see as much benefit with the traditional FOLFOX for patients with Lynch syndrome related cancers. And so now we have the luxury of a different type of medication called immunotherapy that is specifically for cancers related to Lynch syndrome, MSI high cancers, which is basically just a genetic description of Lynch syndrome cancers. You may have seen on commercials the drug Keytruda, and that is an immunotherapy that's had success in melanoma, lung, and kidney cancer. And in 2015, the New England Journal of Medicine showed that this medication also showed promise in colorectal cancer. And so now for patients with MSI high, typically Lynch syndrome related cancers, we are applying immunotherapy. The way immunotherapy works, it's really very interesting. So there is a receptor on all of our cells that can basically cause the immune cell that recognizes it and checks if it's ourself or not ourself, basically turns it off. And cancers have become very sophisticated such that they can also express that receptor and basically turn off the immune system to recognizing them. And essentially what that allows them to do is float under the radar so that the immune system never recognizes them, and then it can grow and develop. That's called adaptive immune resistance. The way that checkpoint inhibitors or immunotherapy works is they block that tumor cell's ability to have adaptive immune resistance, which makes them more recognized by the immune system and more recognizable to immunosurveillance, so that when the immune system recognizes a tumor cell, it clears it out. It works really well when it works. This is a patient of mine who has Lynch syndrome. He had a partial colon resection because it wasn't clear that he had Lynch syndrome at the time that he was diagnosed with cancer. Unfortunately, he developed a recurrence. And so this is the recurrence. You can see the big red arrow is pointing to a soft tissue mass in the left side of the person's belly. He started Keytruda, and at 3 months, that mass shrank. And at 6 months, it was almost gone. And so I took him to the operating room and removed that portion of the remaining cancer and completed his colon resection. So took out the remainder of his colon and hooked his small intestine to his rectum. And I've just seen him for his 3-year follow-up, and he's been cancer-free. And there are a number of trials that are in the pipeline looking at similar medications within immune therapy. We're also doing a couple of clinical trials that look at immune therapy for colon cancer, either stage 3 or stage 4. So it's a really exciting time. We'll talk about FAP and MAP. You can see it's a smaller percentage of people within young onset colon cancer. FAP is characterized by over 100, usually thousands of polyps that carpet the colon in the classical form. They also have polyps that are in the first part of the small intestine, and they have higher risk for developing cancer in the first part of the small intestine. And they also have the risk of developing thyroid cancer and benign growths that are very aggressive called desmoids. The lifetime risk of developing colon cancer with an FAP diagnosis is 100% by the age of 40. As other presenters have said, there's not a whole lot of 100% in medicine, but this one is 100%. So if you have FAP, it is recommended that we remove the colon before the average age that cancer can be seen. And that's usually in teenage or young adult years. For, that's a hard thing for kids to go through, of course. And so again, the decision to pursue surgery is always a judgment call with the patient and the surgeon. But usually we manage to time it so that the person can undergo their surgery either between high school and college, or between finishing college and starting a job, for example, or starting graduate school, depending on whether the extent of their polyps allow for that. There's no report of cancer developing under the age of 12 in people with FAP, so it's at least reasonable to wait until the person is over the age of 12. But they do need to start screening at a younger age than 12 because they'll have polyps and not necessarily cancer by 12. So we start colonoscopies at age 10, and they do them annually. Their upper scopes start at the age of 20, and they have to do them every 1 to 5 years. And anything less than 5 years depends on what the findings are at the time of their scope. If they have polyps, if they're large, or if the polyps show some precancerous change, then they get them done more frequently than 5 years. They also undergo an ultrasound of their thyroid to look for masses, to look for nodules that could be cancer. And then the rest of the screening is basically symptom or risk-based. Sometimes in very anxious people or people who have family history of desmoid or pancreatic cancer, we'll consider imaging for those people. The chemoprophylaxis that we offer to people with FAP is very different than the chemoprophylaxis that we offer people with Lynch syndrome. The purpose of chemoprophylaxis is not to prevent cancer, not to spread out the interval of screening, not to change the standard of care, which is resection in that young adult age. The purpose is to try to reduce the polyp burden to avoid resection of upper scopes, upper polyps, so avoid very morbid resection of duodenal cancers. There's no clear evidence that by reducing the polyp burden, we actually reduce the cancer risk, because the polyps that are left behind could easily harbor cancer. But we do, I'm going to skip this one, but we do offer chemoprophylaxis to people with FAP in the form of Sulindac. Sulindac is a medication that alters the cell cycle and causes cancer cells to die. When you look at randomized controlled trials, you can see that Sulindac significantly reduces the number of polyps that we see in the rectum. Unfortunately, the polyps in the duodenum, that's the first portion of the small intestine, are not as responsive to Sulindac. And sometimes combination therapy is needed to reduce duodenal polyps if the person has a high risk of duodenal polyps. There are some side effects to the combination therapy medications, and of course, all of that should be guided by your physician. Sulindac is also useful in reducing the burden of desmoids. So if you have a strong family history of desmoids, or your mutation is associated with developing desmoids, Sulindac is a good chemoprophylactic agent for those people. And it's a very low risk medication, something that you can take certainly lifelong. Aspirin is not effective for people with FAP, unlike Lynch syndrome. The surgical options for FAP are variable. So it depends on what the person is willing to do, of course. It depends on the distribution of the polyps. And it depends on their sphincter function. So the muscle that controls how they basically poop. The idea is to remove all of the colon and rectum that is involved with multiple polyps. So it can be totally extirpative, which means we take everything out with a total proctocolectomy with endoleostomy. That involves removing all of this colon and this rectum, and the person is left with a permanent ileostomy, which is where we stitch the end of the small intestine to the person's abdominal wall, and the contents empty into a specially made appliance that sticks onto their abdominal wall. If the person does not have a lot of polyps in the rectum, usually less than 20 polyps, then we can save the rectum, and we only take out the portion of the colon, and we hook up the small intestine to the top of the rectum. The person has to be aware that there is a chance over time that they could develop polyps in the rectum that may ultimately require removing the rectum, or cancer in the rectum that may ultimately require removing the rectum. And they have to be willing to undergo surveillance of the remaining rectum. So if a person is non-compliant to surveillance, it's not recommended that we keep that rectum. The more commonly offered surgical option for people, especially young people who do not want to live with a permanent ileostomy, or who have too many polyps in the rectum to allow for an ileorectal connection, is to offer them an ileoanal pouch. An ileoanal pouch is where we take out the whole colon and the rectum, and then we fold basically the last part of the small intestine in half, and we make a new rectum out of the folded small intestine, and then we staple that to the top of the anal canal. So basically, we restore their intestinal continuity by making a new rectum out of their small intestine. For those of you eating breakfast or a little bit faint of heart, you may want to shut your eyes for the next slide. These are some pictures of my operating room and how we make the pouch. This is the last part of the small intestine. We check it to make sure that there's a good blood supply. This is the blood supply that goes all the way to the end of the last part of the small intestine. We fold it in half and make a hole at the bottom of the apex, and we insert a specially designed stapler to staple those two, to connect those two ends of the small intestine. And then we complete the creation of the pouch by putting another special portion of a stapler that allows us to staple the pouch to the top of the anal canal. And when it's done, you can see it basically functions as a new rectum, which is basically a reservoir for stool, so that you can hold on to it when you need to. You can do the things that don't involve toileting, and you can voluntarily empty stool when it's convenient for you. This is another emerging familial syndrome, I'd say. It's the POL or POLD syndromes that was first described in 2013. The other term for it are the PPAPs, which is basically polymerase proofreading associated polyposis syndrome. It's a mouthful, so PPAP is easier to say. But it is again, it's a newly described, first reported in 2013, collection of polyposis syndromes that arises from having an error in the DNA that makes up these complexes, the POL and POLD complexes, and they're responsible for fixing any errors that can occur when DNA is replicated. When DNA is replicated, it's two strands of genetic information that basically unzips, and then each strand becomes a template for making another strand of DNA. And in the process of duplicating all of that genetic information, errors can occur. And these complexes basically are the proofreaders for that new DNA strand. When there's an error in either one of those, you'll end up with multiple errors, and these tumors, and an increased risk of developing tumors. These tumors are hypermutated, but they're microsatellite stable. So it's possible that some of the cancers that we've identified in people before 2013, let's say, that were microsatellite stable, assumed to be not Lynch syndrome, could be related to these PPAP syndromes. The families that have been found to have POL or POLD have colon adenomas. In POL, they'll also have a risk for duodenal adenomas, so this first part of the small intestine, and they can have brain and skin cancers too. For POLD1, they can have colon adenomas and colon cancer. They can have uterine cancer, breast cancer, and brain tumors. It's important to note that in the families that have been described as having these, they didn't have a ton of polyps. So these are cumulative numbers of polyps, greater than 5 polyps, greater than 5 polyps. So it's possible that many of the familial syndromes, again, that we knew about, where families had trends of these cancers, but didn't have a lot of polyps, but didn't have Lynch syndrome histology on their cancers, could actually be PPAP related cancers. Back to that schematic of young onset colon cancer, you can see that we went through the majority of the top half of the screen, but the whole bottom half of the screen, those young onset people with colon cancer don't have a familial cause. And we really don't know why these unfortunate people ended up with cancer. But we think that much of it could be environmental. Let me just see what time it is right now. I'm sorry, I think I've stopped sharing my screen.
No problem, Dr. Wells. We are we're at 10:45 now.
Yeah.
And we do have a couple questions. You just want to answer maybe 1 or 2 questions?
Sure,
Or
yeah,
did you have anything you wanted to wrap up with?
Sure, I'm happy to do that.
Okay, sounds good. One of the questions that came in was any chance of proactive Keytruda strategy?
No, so Keytruda is like a chemotherapy agent. It's not called chemotherapy, it's immunotherapy, but it's really only recommended for people that have cancer. It's not a preventative strategy.
And another question that came in was, is there a geographic chart on the increase in colon cancer? So are there certain geographic areas where we're seeing that increase?
I'm going to share my screen again, even though I won't finish the talk, because that's exactly what the next screen, that's exactly what the next slide is. There we go. So yeah, this is a really nice map that looks at the variation in colon cancer incidence across the globe. And the very dark green is the highest incidence. And you'll see that it's really basically all of westernized countries. And we think that the reason why that is because there are a number of trends that we see in those westernized countries that increase the risk of developing cancer, like obesity, sedentary lifestyle, smoking, and in some ways a high Western diet, which is high in processed meats, red meats, and low in dietary fiber.
Perfect. And I think you just answered one of the other questions about an increase in change because of diet, or increase in the chance of colon cancer because of diet as well. So that's perfect. One last question. This person had radiation to treat their cancer in their spine, and radiation went to the abdomen and GI area. Could this lead to a higher risk of colon cancer later?
Yes, people who've received radiation to their abdomen are at higher risk for cancer. And so they're recommended to undergo colonoscopy in their 40s and every 5 years.
Thank you so much. And thank you so much, Dr. Wells, for your great thorough presentation. Any other questions that didn't get answered now, we'll try our best to answer those. And then maybe in the gene specific breakouts later, that might be a good time to ask those questions and get those questions addressed. So thank you everyone for your thoughtful questions. And we'll go ahead and move on to Dr. Kabilyan's presentation on pancreatic cancer screening and therapies. And I'll introduce her here in a moment. So Dr. Nisa Kabilyan is an associate professor at UT Southwestern's Medical Center, Department of Internal Medicine. She serves as the clinical chief of division and digestive of liver diseases, as well as medical director of endoscopy services at UT Southwestern. She also directs the multidisciplinary pancreatic cancer prevention program and is the co-director of the cancer genetics program at UT Southwestern. Dr. Kabilyan earned her undergraduate degree in nutritional studies from the University of Florida and her medical degree from the University of Miami Miller School of Medicine. She completed a residency in internal medicine at UT Southwestern in 2006 and was selected to serve as chief medical resident. After a fellowship in gastroenterology at the University of Miami, Dr. Kabilyan pursued an interventional endoscopy fellowship at the University of Michigan. And we're delighted to have Dr. Kabilyan here to present. Dr. Kabilyan, are you able to share your screen and share your slides?
I am. Give me just 1 second. Let's get that going. Share screen. Here we go. Okay. All right. Are you all able to see my screen?
Yes, thank you so much.
Okay, great. Kelsey, thank you so much for the introduction, and thank you all for being here this morning. Thank you for the opportunity to spend a little bit of time with you all. I'll tell you, as a physician, having the opportunity to speak to such an informed group of patients, rather than lecturing to other physicians, is always such a pleasure. It's interesting to hear from you all what's on your mind. And as I scroll through the participant list, it's not just many of my colleagues that are on this call, but also many of my patients. And so it's really a pleasure to be here with you all today. Okay, so we are going to spend the next little while talking about what we can do these days to prevent pancreatic cancer in 2020. Oh, here we go. So as we all know, pancreatic cancer is an incredibly aggressive disease with a 5-year relative survival of 10%. And what that means when you think about it in simple terms is hopefully you can see my mouse moving over the slide as well. Out of these 100 individuals diagnosed with pancreatic cancer here in gray, only 10 of these will be alive at the 5-year mark. And obviously, those are sobering statistics and an indication that we're not where we need to be in 2020. One significant factor in how patients do after the diagnosis of pancreatic cancer is the stage of disease at the time of diagnosis. And unfortunately, again, you can see here that most patients, or 52% of patients, have distant or metastatic disease at the time of diagnosis. 30% of individuals have regional lymph node involvement, and only 11% have disease confined to the primary site. And as you might expect, obviously, survival is best for this small segment of the population that's diagnosed with localized disease. Those individuals diagnosed with distant disease or metastatic disease obviously have terrible 5-year relative survival rates. And so my interpretation of those last 2 slides can be summarized with this picture. So I think this is us here in medicine and science, and we've been showing up and we've been playing the game for the past many decades, but you can see that unfortunately, even though we're out there, we're still coming up very short in this battle. Despite our best efforts, we're not yet winning the game. And let's shift gears and talk for a minute or two as to why this disease is so difficult to detect and to cure. I'm going to give you just a little bit of an anatomy lesson here. So this is the liver up here. This is the bile duct. Bile duct drains all of the enzymes that the liver makes down into the intestine. And you can see this tan organ right here. This is the pancreas. And what I want to point out on this slide is how I guess, poorly situated the pancreas is, how close it is to other very important structures in the body. So this is very important vascular supply to the liver. This is the aorta here. And as you see the proximity of the pancreas to other important structures in the body, you can understand why these tumors are frequently unresectable or not removable at the time of diagnosis. Patients with pancreatic cancer can really present in a variety of different ways. Many of them present with vague abdominal pain or back pain, nausea, unexplained weight loss, loss of appetite. And for many individuals, jaundice or yellowing of the eyes and skin can be the first presenting symptom. But again, the point I want to drive home with this slide is that many of these symptoms are incredibly vague and nonspecific and can contribute to a delay in diagnosis. If I had a nickel for every patient that I have seen that says, I had terrible back pain, I saw a chiropractor, I saw my primary care doctor, nobody could figure it out, and it wasn't until 6 months or a year later that they presented with jaundice and we finally figured out what the etiology of their symptoms had been. So one incredibly important advancement in the field has been understanding that pancreatic cancer actually develops through a number of predictable steps. So I want you to focus over here and see that the cells of the pancreas all start out looking very similar to one another. And they progress through a series of very predictable steps, and through these steps, they become ultimately more and more disorganized. This increasing disorganization ultimately culminates in the development of cancer. And once a tumor develops, obviously, it can disseminate and can ultimately metastasize widely, meaning spread through the body. Our goal in 2020 is to identify lesions over here in this stage before they actually ever turn into a cancer. And I think that that's really a critical message in my talk today. We're trying in 2020 to identify early cancers or lesions in this stage over here before they ever actually turn into a cancer. So in order to identify those individuals with precancerous lesions and with early cancers, I think it's critical that we understand who's really at highest risk of developing pancreatic cancer. And so we know that patients with certain types of pancreatic cysts, patients with certain genetic conditions, and those with a family history of pancreatic cancer are at increased risk when we compare them to the general population. And unfortunately, again, because pancreatic cancer treatment options are still so limited, our goal really needs to be to identify high-risk lesions and intervene before a cancer ever develops. So let's briefly talk about the first at-risk population, and those are individuals with pancreatic cysts. So more and more these days, individuals are undergoing radiographic studies for a variety of reasons. This is a simple CT scan of a patient who presented to our emergency room with appendicitis. And you'll see on this scan, again, that this lesion here, this is a large pancreatic cyst that has absolutely nothing to do with the reason the patient presented, right? The patient presented with appendicitis, but had a CT scan identifying this large pancreatic cyst. And historically, over the course of the past decade or so, pancreatic cysts were treated like cysts on the liver, cysts on the kidney that actually have no potential to turn into cancer. Now we know that pancreatic cysts are different and that a proportion of these cysts can evolve into pancreatic cancer over time. So it's not okay to just ignore these cysts like we had done for many decades, actually. These precancerous cysts in the pancreas typically fall into two main categories. The first category being intraductal papillary mucinous neoplasms, and that's obviously a mouthful, and so we've given it the nifty acronym of IPMN, and mucinous cystic neoplasms, or MCNs, and we'll talk about those in a bit more detail. So without getting into too much of the weeds, IPMNs come in two different flavors. The first type here, so again, let me just remind you, this is the pancreas. This is the main highway in the pancreas that delivers pancreatic enzymes into the intestine. And the main the main duct in this variant, you can see, is normal, but the side branches have gone on to develop these little cysts. This category, or this type of cyst, is called a multifocal side branch IPMN, again, meaning that the side branches of the pancreatic duct have gone on to evolve these cysts. The other type of IPMN is one that involves the main duct, or this highway right here. And I want to point out that these cysts are actually very common. They're identified in nearly 10% of individuals over the age of 70, and it's only a small proportion of these that go on to become pancreatic cancer, but certainly this is a recognized path to pancreatic cancer and does put an individual at higher risk than the general population. The second category of precancerous cysts are these mucinous cystic neoplasms. These almost exclusively occur in women. Again, I want to point out the pancreas here, and in this region of the pancreas, the tail of the pancreas, we commonly see these lesions called mucinous cystic neoplasms. And so obviously I recognize that I'm attending or speaking at a hereditary cancer conference today, not at a pancreas cyst conference. So why have I just spent the last few minutes telling you all about these cystic lesions? Well, now we know that the presence of pancreatic cysts in patients with underlying genetic mutations may actually represent a double whammy, if you will, and further increase an individual's risk of progression to cancer. So I think it's particularly important to keep an eye on these lesions in patients who are already at high risk due to an underlying genetic mutation. So let's come back to the question of who's at risk of developing pancreatic cancer. We talked about patients with cysts, but let's switch gears and talk about individuals with a family history of pancreatic cancer. If we go back to data that came out of Johns Hopkins nearly 15 years ago, at that point, we were first starting to recognize that pancreatic cancer tends to cluster in certain families. And as we compare the risk of pancreatic cancer in the general population over here to those to the risk of pancreatic cancer if your family has 1, 2, or more than 2 individuals with pancreatic cancer, you can see that as the number of family members increases, the risk increases significantly. And so what's responsible for that familial clustering? This is a long list of pancreatic cancer susceptibility genes. Again, these are genes, germline mutations that we know increase an individual's risk for developing pancreatic cancer as well as other cancers. And I think it's incredibly important to note that if you went back a decade, this list would be much shorter. And I think if we fast forward a decade, this list is going to be much longer. So there are certainly families that have clusters of pancreatic cancer, or a number of individuals with pancreatic cancer in whom we have not yet identified the underlying germline mutation. But here, I know that many of these mutations are familiar to those of you in the audience, and you can see that the risk of developing pancreatic cancer is increased above the general population for all of these mutations, but there's a great deal of variability depending on what particular mutation an individual has. So take, for example, the mutations associated with hereditary breast and ovarian cancer. You can see a BRCA1, BRCA2 mutation can increase an individual's relative risk of pancreatic cancer anywhere from 2 to 9 times. Let's take an STK11 mutation, which obviously occurs in individuals with Poitz-Jaeger, and that may increase an individual's risk of pancreatic cancer 132 times. So my point is that each of these mutations increases the risk, but certainly the particular mutation increases the risk variably. I think it's worth just briefly mentioning we've talked about the hereditary breast and ovarian cancer genes and Poitz-Jaeger. I think it's worth mentioning that now we know ATM gene mutations, which are found in ataxia telangiectasia, CDKN2A and P16, which occurs in the FAM syndrome, familial atypical multiple mole melanoma, the Lynch syndrome mutations, which you heard also in the previous speaker's lecture, PRSS1 and APC, which is seen in familial polyposis, again, increase the risk of developing pancreatic cancer, as well as a number of other GI tract malignancies. So are there particular factors we need to consider when we think about who we need to screen for pancreatic cancer? Obviously, we don't screen the entire population like we do for breast or prostate cancer, and that's because in the absence of certain factors, the risk of developing pancreatic cancer is relatively low. So it turns out that your family history, specifically the number of first and second degree relatives with pancreatic cancer, your germline mutational status, and your age are the key variables in predicting the need for screening. So how significant does your family history have to be in order for you to begin screening or to warrant screening? And I want to just drive home the point. This is in individuals who don't have a known germline mutation. I'm frequently asked, so what if I don't have a mutation, but my dad died of pancreatic cancer? Do I need to start screening? And the answer to that is no. Family history in one blood relative is not felt to represent a high enough risk to warrant screening. That number jumps up pretty significantly to an 8% lifetime risk if you have 2 first-degree relatives with pancreatic cancer. And I want to frame that 8% in the context of the general population has a 1.5% risk of developing pancreatic cancer in their lifetime. So 8% is actually very significant. And our most recent guidelines suggest that any individual with 2 first-degree relatives with pancreatic cancer should undergo screening. So what are the most recent recommendations if you have a known germline mutation? So individuals with BRCA mutations, ATM, PALB2, and Lynch syndrome mutations should undergo screening if they have at least 1 first-degree relative. Again, if you have an underlying mutation and you do not have a first-degree relative with pancreatic cancer, you do not necessitate pancreatic cancer surveillance. That's different for individuals with a CDKN2A or an STK11 mutation, again, because of the incredibly high lifetime risk associated with these conditions. So irrespective of your family history of pancreatic cancer, individuals with these mutations should undergo pancreatic screening and surveillance. And when do we start? When do we start surveillance? So individuals, again, with the BRCA mutations, ATM, PALB2, and Lynch syndrome mutations should start at the age of 50 or 10 years younger than the youngest affected blood relative. So if you have a BRCA mutation and your father had pancreatic cancer at the age of 50, you should actually start screening at the age of 40. Everybody with a CDKN2A or STK11 mutation should start screening at the age of 40, irrespective of, I guess actually we could start earlier than the age of 40, but certainly not after the age of 40, irrespective of your individual family history. And so we've made the decision that somebody may benefit from screening. How do we screen? What screening tools do we have? So typically we use some combination of MRI, MRCP, which is a very fancy type of MRI that specifically looks at the biliary tree and the pancreatic duct. Endoscopic ultrasound, and we'll talk about that in the next slide just a little bit. And the use of fasting blood glucose and or hemoglobin A1C. Hemoglobin A1C is actually a reflection of the last 3 months worth of glucose measurements. And we don't quite have an evidence-based consensus yet on what combination of these studies are best. And so depending on each individual and which screening program you're a part of, a variety of these different tools are utilized. Let's talk about endoscopic ultrasound for just a second, for those of you who haven't heard of it before. So this is a minimally invasive procedure. You can think of it almost as an upper endoscopy that allows us to very closely examine the pancreas. So we're able to insert a camera through the mouth, drive it down through the esophagus, through the stomach, and line ourselves up with the pancreas. The stomach, you may remember from my earlier slides and from this slide, lines up very nicely with the pancreas. At the tip of our scope, there's actually an ultrasound probe that generates high frequency sound waves to produce very detailed images of the pancreas. And through this scope, we're actually able to biopsy the pancreas should we find a mass that needs to be biopsied, or a lesion, an area that we think is potentially at high risk of being pre-malignant. Let me show you this video quickly. So this is a video of an endoscopic ultrasound. This is, I know it looks like shades of gray to most everybody. The blue dots that you see are blood vessels. We're able to ensure that there are no blood vessels in the path of our needle. And you can see through the endoscopic ultrasound scope, we're able to put a needle into this rounded mass in the pancreas. Typically in the room, we have a cytologist who's able to look at the slides and actually make a diagnosis for us at the time of the procedure. So again, before I go to this next slide, I'm sorry, just making the point that even in individuals at high risk, we want to be finding these lesions before they ever actually develop into an overt tumor like you see on the screen right now. But the endoscopic ultrasound is useful for early tumors and also just for assessing high risk areas in the pancreas that we think may go on to become tumors down the road. And so the last screening tool we rely on is the trend of a person's blood glucose level. And it's estimated that 50% of individuals with pancreatic cancer also present with diabetes. And I think the question that was asked historically was whether diabetes was a risk factor for pancreatic cancer. And more recently, the question has been asked in the reverse. So do we think that pancreatic cancer actually causes diabetes? It's kind of the good old adage of which came first, the chicken or the egg. And I want to just point out some data that came out in 2018 that I think is really very eye-opening. If we look back at individuals who eventually went on to develop pancreatic cancer, and you can see that here in this blue graph, you can see that hyperglycemia or elevated blood glucose developed in these individuals up to 3 years before they ever went on to develop a pancreatic cancer diagnosis. In these individuals, they went on to develop diabetes 6 to 12 months before ever developing pancreatic cancer. And I think the point here is that we really need to be paying more attention to hyperglycemia in high-risk individuals way before a pancreatic cancer ever develops. The point being that this may be a harbinger of an impending pancreatic cancer diagnosis. And this is felt to be such a significant finding that now, if you have a high-risk individual, somebody who has a germline mutation, for example, or a family history of pancreatic cancer, and if they develop new onset diabetes, that immediately should lead to the initiation of screening and evaluation for an underlying tumor. And the last piece of recent data that I think is important to share with this group comes out of the most recent NCCN guidelines. So we know that patients with pancreatic cancer who have no family history of any sort of cancer, the risk of genetic mutations is still incredibly high. And so the recommendation has been made that every single individual who goes on to develop pancreatic cancer have genetic testing. And this is really important because the results of these genetic tests now are actually being used to guide the use of particular treatments and inform patients, obviously, and their families about the risk of future cancers. I think this is particularly important, and I guess the best example of being able to use this data now is in patients with BRCA mutations, where now we know that we have direct targeted therapies, platinum-based therapies and PARP inhibitors, which are proving to be very beneficial in the treatment of pancreatic cancer if you have an underlying BRCA germline mutation. So what hope is there out there on the horizon? In 2016, we launched the Pancreatic Cancer Prevention Program at UT Southwestern, and the goal of this surveillance program, and of all surveillance programs really, is to identify individuals at high risk of developing pancreatic cancer and monitoring those patients, again, hopefully to ever develop a cancer, to prevent a cancer from ever developing. Our program is comprised of a multidisciplinary team of experts from specialties including radiology, gastroenterology, surgical oncology, and cancer genetics. And again, everybody in this group is dedicated to screening high-risk individuals. And as we've talked about, obviously numerous times already today, until we have really more effective treatment strategies, the best tool we have is preventing a pancreas tumor from ever developing. So what do we do? How does a screening program work? Patients can be referred into the program by their physicians, or can actually just refer themselves by calling us. When a referral is received by our program, patients are evaluated by our navigator. We obtain a family history and we decide if a patient needs to be seen by cancer genetics to discuss the benefit of germline mutational testing. The need for additional imaging in the way of MRI or endoscopic ultrasound is arranged. And then I think the highlight of our program, at least, is that we all sit down on Friday mornings at 11 o'clock, the surgeons, the radiologists, the gastroenterologists, and we actually review every individual's history and imaging prior to them ever being seen in the clinic. Ultimately, an appointment with a gastroenterologist or a surgical oncologist is set up, and then ongoing surveillance or other testing is arranged for individuals. And I think as screening programs become more common across the country, we're starting to see improved outcomes for high-risk individuals in these programs. So specifically, cancers detected as part of a screening program, this is based on the CAPS consortium out of Hopkins in 2018, we see that cancers detected as part of a screening program tend to be smaller and have a better prognosis than cancers that are detected once an individual has symptoms. So typically, again, these cancers are surgically resectable, and if you remember back to one of my early slides, that's not typically the case when an individual presents with pancreatic cancer. And again, the overall survival for these individuals is dramatically better when these cancers are diagnosed in a surveillance program because they're caught early as compared to when they're caught outside of a surveillance program. So in summary, we know now that several genetic syndromes contribute to the risk of pancreatic cancer. Precancerous lesions obviously can be identified in 2020 before the development of a pancreatic cancer, and that's really where the focus our focus needs to be. Genetic counseling and testing is an important part of pancreatic cancer surveillance, prevention, and management. Surveillance of high-risk individuals can and should be considered in large centers with a multidisciplinary approach to caring for these patients. And I think as these surveillance programs continue to evolve, I think we're going to start to really see the benefit. We're already seeing some of it, but really start to see the benefit of surveillance. So I'm going to leave you with this slide. My sincere hope is that by the time this group meets again next year, the prognosis, the outcomes, and the trajectory of this devastating disease will hopefully be incredibly different than they are today. And so with that, I'll stop, and I'll be happy to take any questions you all may have.
Thank you so much, Dr. Kabillian. So much insight you bring us. And we did have a couple questions come in, so we'll just take a few here. And any
Sure.
questions we don't get to, I'll try to chat with each person individually to get those questions answered. But one person says they also have chronic pancreatitis and a BRCA2 mutation. So does that pancreatitis play a role into their risk of cancer?
Yeah, that's a fantastic question. So outside of germline mutations, one of the highest risks that we know of for developing pancreatic cancer is underlying chronic pancreatitis. It's actually a paradigm in medicine where we see that chronic inflammation leads to cancers in a variety of different organs. So I would say absolutely, when we talk about sort of a two-hit phenomenon, I think an individual with chronic pancreatitis and an underlying germline mutation is at increased risk and certainly warrants very specific surveillance. So important to meet with their doctors and talk about the effect, the compounded effect from those two risk factors.
Thank you. Another question, have there been any studies conducted of BRCA1 and 2 variants which are more susceptible to pancreatic cancer specifically? She knows that Mayo tracks some of their patients in this regard, but she's not aware of any studies, or are there any PARP inhibitors standard of care now for the state of Texas for BRCA1?
That's a great question also. So I don't know of any particular variants that are necessarily individuals with BRCA1 or BRCA2 variants that are at higher risk of developing pancreatic cancer. Certainly we know that the BRCA2 gene is a higher risk than BRCA1. I don't know that we are specifically tracking our BRCA patients with their particular BRCA variants to recognize whether or not they are at higher risk. PARP inhibitors have not yet become the standard of care in the state of Texas for BRCA1. They are typically used, the New England Journal of Medicine article that really, the POLO trial, which really highlighted the use of PARP inhibitors back in 2018, focused more on individuals who had been treated with platinum-based therapy first. So it is not yet in any clinical trial, outside of any clinical trial format, first-line therapy.
Perfect. We'll go ahead and wrap up now and transition to our next presenter. And then any other questions in the chat, I'll definitely respond to you individually and get those questions answered. Thank you so much, Dr. Kabillion.
Thank you again for the opportunity to spend time with you all this morning. Appreciate it.
All right, next up we have Dr. Litton, and I will introduce her here real quick, and feel free, Dr. Litton, if you would like to start sharing your slides while I introduce you, that works for us. So Dr. Jennifer Keaton Litton is Vice President and Interim of Clinical Research and a professor of the Department of Breast Medical Oncology and Clinical Cancer Genetics at the University of Texas MD Anderson Cancer Center. She holds an additional faculty position in the Graduate School of Biomedical Sciences at the University of Texas Health Science Center in Houston. She attended Duke University with degrees in English and history and the University of Massachusetts Medical School. After completing an internal medicine residency at Baylor College of Medicine, she then served as chief medical resident. She completed a fellowship in medical oncology, the University of Texas MD Anderson Cancer Center, before joining the faculty in the Department of Breast Medical Oncology, where she served as chief section of clinical research and drug development. Her research interests include the treatment of young breast cancer patients, including the treatment of breast cancer during pregnancy, treatment-related infertility, hereditary cancer syndromes, immunotherapy, and triple-negative breast cancer. She is a principal investigator for multiple clinical trials. She serves as a member of the National Cancer Center Network National Guidelines Panel for Hereditary Breast and Ovarian Cancer Syndromes, and has been appointed to the Breast Immuno-Oncology Task Force of the National Cancer Institute Breast Cancer Steering Committee and co-chair of the Society of Immunotherapy of Cancer Breast Cancer Subcommittee. She has authored multiple abstracts, peer-reviewed journal articles, and book chapters. Dr. Litton has served on the boards of St. Luke's Episcopal Health Charities, the Children's Fund, Sweets of Hope, and alumni of Texas Lycum. She lives in Houston with her husband, Todd, and her 3 kids, and we're very much looking forward to your presentation today. Dr. Litton, take it away.
There we go. Thank you. Hello, everyone. Thank you so much for inviting me to talk with you this Saturday at your conference. I know all our conferences are a little strange these days, but being not in person, but I think we're finding ways to keep connected. So today I was asked by the organizers to briefly go over just some of the hereditary breast cancer genes that we'll be talking about, and to spend a little bit more of the time about some of the research that's going on for clinical trials. So here is my disclosure. I work with many different companies, but have refused all honorarium for the entirety of my career. So today we're going to talk about hereditary breast cancer syndromes, screening and prevention, and then treatment recommendations. So when we think about risk factors for breast cancer, there's many that we've known for years and years, some that we can change and some that we can't. But when we think about that in the background of having a hereditary cancer syndrome, such as having a pathogenic variant in BRCA1 or 2, they really seem to be more in the background. And in addition to mammograms, since the guidelines came out for MRI screening in 2007, we've really leaned on MRIs with high sensitivity of finding things. And I would say early on, the specificity, so in other words, they would see a lot of things, but couldn't really tell us if those things were important or not, and led to a lot of biopsies. And that's really improved over the last decade as we've had more experience with MRIs. Now, mammography alone still, I would like to say, has benefit in this situation for screening. Sensitivity alone is lower in high-risk populations, but when we put both mammogram and MRIs, we really see the best sensitivity of finding cancers. But for many of you on this call who've experienced MRIs, you know that they can be expensive. They can be really difficult as you're lying in that position for 45 minutes to an hour. It's loud, it's time consuming. I do want to tell you that there is good news. There are multiple new trials looking at other imaging techniques, shorter MRIs, and novel imaging such as molecular breast imaging that is coming into play, and I suspect will change our screening guidelines in the future. So let's just talk briefly about some of the hereditary cancer syndromes. I'm going to kind of go through these a little bit quickly so we can have more time for discussion. But know that when we're thinking about guidelines and we're thinking about who should screen and when and should you get a mammogram or MRI, I just want to say from the start, these are in general, but a lot of times spending time looking through your particular family history and the ages of onset when we have that information, that these recommendations may change. And so it's really important to spend time looking at your personal family history and just know that recommendations may change. So BRCA1 and 2, we have known about these for some time now and tend to still have the highest risks of developing breast cancer. And it's not just breast, it's ovarian, male breast cancer, prostate, and as we just heard in the previous speaker, pancreatic and melanoma. We used to do mammograms in your 20s as well and realized that they really weren't adding much to the sensitivity of MRIs. So MRIs in the 20s and then adding mammograms at age 30. At MD Anderson, we tend to do every 6-month imaging with a yearly mammogram, staggered every 6 months with a yearly MRI, just so that we can have some sort of imaging in between and not wait a full year. I will say during COVID, I have a lot of patients who it's just not working out and they'll come in and do both at the same time. Also very reasonable. After age 75, we really look at an individual basis. And this has been a new part of the guidelines really to give some idea of when MRI maybe doesn't add much more to mammograms because of the change in the density of breast tissue. And I think there'll be more for that. Now, metastatic prostate cancer testing for men. And now because of the PARP inhibitors, really, I think any woman with metastatic breast cancer should have testing that includes looking for BRCA1 and 2. Discussing risk-reducing mastectomies or having your ovaries out. And there are some newly defined small risks for uterine cancer, and that may take into account considering removing the uterus as well. Prostate screening earlier for BRCA2, consider for BRCA1. Of course, we'll always look at the family history. And I would also like to recommend, based on what you also just heard, participating in a pancreatic screening program if there's one available to you. Li-Fraumeni syndrome, this is the P53 gene. I want to just say one thing that comes up sometimes in clinic, and this has to go to patients with triple negative breast cancer. And now that we're doing a lot of genetic testing or genomic testing on the tumor itself, so not what's inherited, but what's driving the tumor when it's identified, is that for patients with triple negative breast cancer, this gene is mutated in about 80+% of triple negative breast cancer. That doesn't mean it's inherited per se, and that's something that we often have to look at and describe the difference of that, as we're doing that now on tumor tissue. So risk of any cancer with Li-Fraumeni is about 90% by age 60. We are seeing a difference in the types of breast cancers that are identified. They tend to be much younger and HER2/neu positive breast cancers. There's increased risk of multiple other cancers. And if we see malignant phylloides, we will test for this. We will start with yearly MRIs, colonoscopy, endoscopy, dermatology exams. We do discuss risk-reducing mastectomy. And now the recommendation of whole body MRI that should include imaging of the brain. Cowden syndrome, this is for the P10 gene with 25 to 50% lifetime risk for breast cancer. There are some benign features that we look to: macrocephaly, which is large diameter of the head, and different findings that a dermatologist might find on the skin or under the tongue or in the mouth. There's increased risk for breast, thyroid, and endometrial or uterine cancers. We do recommend annual mammogram and MRI starting at age 30. We do discuss risk-reducing mastectomies, endometrial screening and awareness at age 35, and considering hysterectomy after childbearing. Annual thyroid exam starting at age 7. This is one of the genes that we will go in and look at pediatric populations for the thyroid exam, renal ultrasounds, and colonoscopies. Peutz-Jeghers, this is the STK11, lifetime risk of 30 to 50%. Still not enough evidence for routine recommendation of risk-reducing mastectomies, but certainly this and in any strong family history can be considered. There are benign features, but significant risk for colorectal, gastric, pancreatic, breast, and ovarian cancers. And females are also at risk for sex cord tumors. Hereditary diffuse cancer syndrome, this gene is the CDH1. And we do have a group of patients we are following here at MD Anderson with this. The biggest risk for patients who have a CDH1 mutation is gastric cancer. These are the patients that often will choose to prophylactically remove their stomach, and it's associated with lobular breast cancer as well. Annual mammogram and MRI starting at age 30, and discussion of risk-reducing surgeries really based on the family history. I want to take a little time to mention PALB2. You know, PALB2 has been followed and noted, and at first thought to be maybe not that much of a player. And as we continue to get more information about PALB2, I would really, in my mind, I think of this similarly to BRCA2. The risk seems to be the same, and I consider now the same management and treatment as BRCA2, with the addition that we recommend yearly mammogram and MRI starting at age 30. And we're going to come back to PALB2 when we start to talk about the different therapies for cancers. CHEK2, this is a very common mutation we've seen, and this where the question for the last speaker, this one, there's a specific mutation that tends to be the one we see, this 1100 del C. There are some very other rare CHEK2 mutations that carry a less risk of breast cancer. This tends to be the one we see more likely. And increased risk of breast cancer, 20 to 25%. But again, we put it in the context of family histories. There's certainly some families where we see much higher risks. Potential risk for ovarian, prostate, and colon cancer. We are recommending colonoscopy every 5 years, beginning at age 40, and yearly mammogram and MRI starting at age 40. For ATM, this is one I hear a lot. Now that we're routinely testing more and more people who are diagnosed with breast cancer, this is one that we frequently find in the general population of about 1%. It has an increased risk of breast cancer, about twofold, 20%, and yearly mammogram and MRI starting at age 40. One of the misconceptions, I think, with this gene is that there is a hereditary syndrome if both genes have the same mutation, and puts people at risk for radiation therapy, but that is not the same risk as people who find heterozygous or a mutation in one of their genes. We would have known you had the syndrome, and I've had some people where radiation was withheld, and I don't think that was in the best interest of the patient. And then there's multiple other ones, and you know, if you have a mutation in one of these genes, I think that's really worthy to sit down, go through your family history, and get a little bit more of a personalized risk assessment and plan. Okay, I wanted to make 2 big points about risks of cancer that come up in clinic a lot. So BRCA, we do know that for whatever reason, you know, some people get breast cancer very early, but we know that, for example, you know, if you're 30, your risk, and you have a BRCA mutation identified and you don't have breast cancer, yes, we do share a very high percentage risk of developing breast cancer. But it's very different when someone comes in and they find out they've had this mutation and they're 70 and they've never had a risk of breast cancer. There is a point where you outlive a bit of your risk that if you haven't had that event by a certain age. And so an unaffected individual that we're counseling may have different recommendations if you're 30 versus you're 75 as far as screening and risk reducing surgeries. The other thing that we get a lot in clinic is the risk of a second breast cancer. So when you're thinking about bilateral mastectomies, what are your risks? And I will just say that I don't think bilateral mastectomies are a necessity for every person with a known mutation who has breast cancer. I think it's really individualized. But when I think of this, I think, you know, if you're under the age of 40 and you have your first breast cancer, well, then your risk of getting a second unrelated breast cancer in your lifetime is over 60%. And so that 35-year-old woman with breast cancer may make a different surgical decision at the time of the definitive treatment for their breast cancer than someone who was 70 with their first breast cancer, who may look more to lumpectomy or bilateral mastectomies, but looking at this data. So I wanted to talk a little bit about treatment recommendations for people who have a mutation and have been diagnosed with breast cancer. Now, we've known for some time that people with a BRCA mutation seem to be more susceptible to different chemotherapies versus others. And when we look here at this TNT trial, it was a small number of BRCA mutation carriers who had a triple negative metastatic breast cancer, but they compared Taxotere, which is a common chemotherapy, versus carboplatin. There was really no difference across the board in triple negative breast cancer, but they really saw a significant difference in the BRCA mutation carriers who got single agent Taxotere versus single agent carboplatin, really having much more benefit from the carboplatin. There's been a couple trials looking at, well, if we put carboplatin together with a PARP inhibitor, do we get different results? And they've been a bit mixed, and we'll talk about that. So first, I'd like to start with the PARP inhibitors. There are 2 PARP inhibitors now that are FDA approved for patients with locally advanced or metastatic breast cancer who have a germline BRCA mutation and they don't have HER2 positive breast cancer. And the reason we kept HER2 positive out of these 2 trials was that there's so many other really great targeted therapy for HER2 that we think that people with HER2 positive breast cancer should get the benefit of those drugs. So both of these trials look very similar. They were patients with metastatic triple negative breast cancer and randomized 2-to-1 to either the in the Olympiad, it's olaparib, that's 300 milligrams given twice daily versus a physician's choice of chemotherapy. And in the Embraca trial, again, a 2-to-1 randomization to talazoparib. It's a once-a-day pill versus physician's choice of chemotherapy. Slight difference is that during the time of both of these trials, carboplatin, there was that TNT trial I talked to you about earlier where people were now adding that platinum-based chemotherapy in. And so both trials started to allow previous platinum therapy, but as long as they didn't grow on platinums. It's also one of the biggest criticisms of both trials is that the platinums weren't in the comparator arm. And the reason is because both carboplatin and PARP inhibitors work on very similar pathways, and they also have very similar mechanisms of resistance. So both trials allowed it, but both trials did not allow you to have progressed or have the tumor grow on it. And both trials have very similar findings with an improvement in progression-free survival from a as you can see here, and both were statistically significant, so showing an improvement. Now, interestingly, and we do know it's hard to show overall survival in metastatic breast cancer given how many therapies we have now, but when we look at both the Olympiad and the Embraca, there was no statistically significant difference in overall survival. During the time of Embraca, I will say that the Olympiad trial, the olaparib did become available. And so there was a large portion of patients who went on after this trial to get either the carboplatin or the PARP inhibitor. But regardless, no overall survival in the intention to treat population. But I wanted to mention a couple things about this, and this is Dr. Robson here did an extended follow-up of the Olympiad and looked at multiple different ways in people that they were following. And there looked at patients who have more than one line of chemotherapy, what their tissue receptor subtype, so was the tumor triple negative breast cancer or hormone receptor positive? Did they have any prior exposure to platinum? And they really didn't see anything different. The only one that they started to see a different, again, this is exploratory, it's not pre-planned, but interesting is that if it was the very first thing that you gave to someone with no prior chemotherapy. Now that doesn't mean that if you had a hormone receptor positive breast cancer and you got a bunch of different anti-estrogen therapy, but it was before you got any other chemotherapy. And they are seeing a difference in this. But what I also find really intriguing is that over 8% were able to stay on single agent, so a pill, for more than 3 years. So we have these really exceptional responders, and we see this in this trial and other drugs such as the CDK inhibitors, where there's a group of patients that for whatever reason have this exceptional response, and we're really trying to dig in to learn more about that. But what I also find intriguing about both of these drugs, this is a class effect, and I can't tell you that one is better than the other, and nor will I ever, because those trials will never be done. But what's really intriguing about, I think, the PARP inhibitors as a class of drugs is that for the patients who were randomized to get the PARP inhibitor versus the patients who were randomized to get chemotherapy, the patients with the PARP inhibitor actually felt better. They started to do more. They had better quality of life. And those patients who were randomized to the chemotherapy actually had a decrease in their quality of life. And when they looked at time to deterioration of just global quality of life, you can see in both trials, so again, I think a class effect of a significant decrease to the time to deterioration. So when we look at the Olympiad trial, the median time wasn't reached. The Embraca, we're talking about a difference from 6 months if you got chemotherapy to your quality of life was maintained for 24 months. So I wanted to say a couple things about combination therapy, and I'm going back to the slide we talked about earlier and really honing in on Brocade 3 and this trial. You know, when we looked at patients, if we keep giving PARP and platinum, and we think if we give more together, it will always be better. I say, well, let's look at that. One thing I want to mention before I show other data is the GEPAR-6 trial. Now, this is a trial out of Germany where they gave a bunch of different chemos all together to people with early stage breast cancer and saw a difference if they got carboplatin in patients with triple negative breast cancer. And, you know, it included an anthracycline, so that's doxorubicin, the red devil, but you know, everyone thought, well, gosh, if carboplatin is so much better for people with BRCA mutations, we should definitely just put it in that early and add it to all that chemo. And this is one of the first trials that says, well, maybe it doesn't add in this specific. So if we look over here, the patients who had a BRCA mutation and got the carboplatin in this trial really had no significant benefit over all the other chemo cocktail that they got at that time. So let's talk about the Brocade 3. And I think that this has been a little bit more of one of the controversial trials. So this looked at patients very similar to the Olympiad and the Embraca trial we've just been talking about, with patients with advanced breast cancer and a known BRCA mutation. And they were randomized to get veliparib, which is another PARP inhibitor, carboplatin and paclitaxel versus a placebo and carboplatin and paclitaxel. Now, what's a little bit different about this trial is that you would treat to progression, but carboplatin plus paclitaxel together can be challenging. And so they could be discontinued prior to progression. And if that was the case, then the patients could go on either continuing on their veliparib, but increase the dose to what you would give as a single agent versus a placebo. And they could continue until progression. There was also an optional crossover. So Brocade 3 presented, and it met its primary endpoint of progression-free survival, increasing from about 12 to 14.5 months and a hazard ratio of 0.705. But I wanted to make a couple notes about that. So when we look at the chemo part, the carboplatin and the paclitaxel, the median number of cycles that a patient got was 11 to 12. And it was stopped in a large percentage of patients, and they were continued on either the single agent veliparib or a placebo. So in 40% of patients went on the PARP alone, and 34% went on a placebo only in this trial. So if I go back to the primary endpoint of the progression-free survival, one of my questions is, so at about 8 to 10 months, a large portion of patients went ahead onto either single agent PARP inhibitor versus a placebo alone. And we really don't see that separation of the curves until about that time. So my thoughts when I look at this is more that not that the triplet together makes any difference, because we really don't see much of a signal there, but that using a PARP inhibitor as maybe a maintenance therapy like we do in ovarian cancer may be something for us to explore. Recently, the SWOG 1416 trial looked at doing the same thing about giving a PARP inhibitor with veliparib. This trial really was kind of trying to look at different ideas out there of what to look at. So a lot of patients were in that either had metastatic triple negative or they had a known BRCA mutation, and they were randomized to as before. But post randomization, they went in and they did BRCA testing, so germline alone, but then they went into the actual tumor and assigned patients into pre-specified groups, which is really why this trial is not ever going to mandate new treatment, but is really generating ideas for the next trial that should be happening. So germline BRCA testing was done, and if they had a mutation identified, they were in the germline BRCA group. If it wasn't detected, they looked at a whole bunch of other things in the tumor to say, well, does it look like BRCA? Does it act that way in tumor repair? And they were put into a BRCA-like group and a non-BRCA-like group. Now, when they looked at the distribution, I would just want to mention that when we look at the BRCA group, we're really talking about a small number of people. And then we look at the BRCA-like, 99, and non-BRCA. And several did were unclassified. There was no difference in any of the other groups except for the BRCA-like group, where we do see a signal in differences of progression-free survival and overall survival. Now, this is a really mixed bag group of people with tumors who didn't have a known BRCA mutation, but found something in their tumor. So again, I think very interesting, but nothing we would change therapy for, and could consider a trial based on these findings. Neoadjuvant trials, so for early stage breast cancer, where we look at giving therapy prior to breast cancer. There's been several looking at single agent platinums. I will say that this one looked at a group, this is a Polish study. It had a very high pathologic complete response rate of 61%. There were several veliparib trials. The I-SPY trial is a preoperative therapy that tells us probability that a full trial will be positive or not. And there was some potential that they thought that this should go on to a phase 3 trial, and it did. It went on to the Brightness trial, where they had 3 arms of patients who got paclitaxel, carboplatin, and veliparib, so 2 of the chemotherapies plus the PARP inhibitor, versus paclitaxel, carboplatin, versus just paclitaxel, which is often the standard that we give to a lot of our breast cancer patients. And basically, the veliparib didn't add anything to the paclitaxel and carbo arm, which was the winner. We then did 2 small pilot trials of just a single PARP. We started with 2 months followed by standard neoadjuvant chemotherapy, just to see if we could understand a little bit more of the mechanisms of resistance and response. But what we found was that when we were imaging patients after 2 months, the decrease in the tumor was median of 88%. And our patients were saying, we want to stay on this. We don't want to go to chemo. So we did a phase 2 trial where we treated people with only PARP inhibitor, no chemotherapy, and took them to surgery. And we had a pathologic complete response rate in this small trial of 53%. I wanted to just show you that trial because it's the first trial ever to show a pathologic complete response in patients who didn't receive chemotherapy for triple negative breast cancer. So there were 20 patients in this trial. They received 6 months of the therapy and they were followed very carefully. One patient did go on to get chemotherapy before surgery. So of the 19 remaining patients, we have a pathologic complete response rate of 53%. And if we put together the patients who had all of their tumors gone versus just only a tiny bit of tumor, put those together because their outcomes are very similar, it's about 63%. Now, the INFORM trial also looked at neoadjuvant therapy and went back to really ask the question, does that platinum versus the standard AC chemotherapy, because we've been thinking that the platinums are so much better for everyone with BRCA mutations that maybe we could get rid of the standard anthracycline and taxane-based chemotherapy for our breast cancer patients with a BRCA mutation. Wondering if we could get to that same level. And actually what they found is you cannot. And I think that overall, this is what we also saw in that German trial, is that basically when you use anthracycline for patients, so doxorubicin, for patients with early stage breast cancer, that really still is the best drug, and that a single agent platinum isn't going to be able to replace it, and probably why adding it to a chemotherapy regimen that has already doxorubicin in it, it didn't add anything because you were already getting maximum benefit. So I would like to highlight there's a couple of very exciting future trials in early stage breast cancer, specifically the Olympia trial, which looks at olaparib for people who had preoperative chemotherapy and a germline BRCA mutation, but there was tumor left over at the time of surgery, and then putting them on olaparib to see if we can keep cancer away from more people. There's also a larger multi-center trial looking at just single agent PARP inhibitor. Both have completed accrual. We are waiting for both to report. There are some really exciting future directions, not just in PARP inhibitors, but with multiple other types of therapies. And I wanted to just show you that in addition to BRCA, as we're learning more on the tumor side, that there's so many other targets that relate to BRCA and so many different therapies that are being developed that we think might be very efficacious in people with hereditary cancer syndromes in those DNA repair areas. First, question I get a lot is, well, I don't have BRCA, but I have PALB2. Can I do a PARP inhibitor? We don't have a trial that looks specifically at PALB2, but we do have evidence from multiple trials, and I'm showing one here, that people with multiple different types of hereditary syndromes, and the tumors that decreased and really showed a response were these patients who had PALB2 mutations. ATM really doesn't seem to be responding to PARP inhibitors like BRCA and PALB2, and we're also seeing that in some of the GI cancers, that the ATM mutations really aren't having that same effect. The olaparib expanded trial, which is the TBCRC 048, again, we're seeing very similar things. The tumors, the genes we talked about earlier, the tumors that are still getting the big response here in the green are the PALB2 mutation carriers. The other really interesting part about PARP inhibitors that we have noticed, and from a lot of our research and others, is that when you use a PARP inhibitor, it activates this whole pathway. It's called the C-gas and STING pathway. And what it does is it can increase inflammation in the tumor. It can increase antigens, and really important, increasing PD-L1. Now, PD-L1 is the expression that tells us whether or not the use of immunotherapy might have benefit. And there's been several trials that have reported and multiple ongoing, and I'm just showing one of them. This is the Mediola trial, and it's looking at patients who were given olaparib and this immunotherapy durvalumab for patients with germline BRCA mutated metastatic breast cancer. And what's really interesting about this particular trial run by Dr. Domchek out of Penn is that they gave the olaparib for a month before they added the immunotherapy. And if you think about it, that makes a lot of sense. If you give something that's going to prime a tumor and make it more susceptible to immunotherapy, maybe we should prime the tumor before we give them. And really showing some increased benefit with this combination, especially in the group that got the primer, and less so in the group that didn't get the primer. So when I think about PARP inhibition and checkpoint blockade, when we look at who responded, these are a bunch of different, these are 2 trials that have immunotherapy with them. And here are the 2 single agent PARP inhibitors. Now, we do see the same, really similar, that if you get the PARP inhibitor, we actually get response in over 60% where the tumor actually shrinks. And we don't see a difference with that, which makes sense because immunotherapy takes a while to work. And so the response rates are similar. This is a different PARP inhibitor that's not used yet in breast. But what's really interesting is that we're seeing that there might be a tail on that response, and it might actually increase and lengthen the time that people respond to the PARP inhibitor if we add an immunotherapy. And I think that's what we're all hopeful for, and that still remains to be seen if this pans out in bigger trials. So in conclusion, I think there's multiple hereditary breast cancer syndromes that exist. The penetrance is varied, the recommendations are varied, and your family history should be taken into account for your personal recommendations. We now have targeted therapies that are FDA approved for metastatic breast cancer for patients with hereditary cancer syndromes, and I would advocate that PALB2 should be included in those in many of the ongoing trials. And there's trials evaluating early stage breast cancer and combination therapies with multiple other agents or interventions that are ongoing. So stay tuned for those in the next several years. With that, I'd like to thank you and open it up for any questions that you might have.
Thank you, Dr. Linden. So great to see all the research that's going on right now. One of the first questions we got was if you've had a bilateral mastectomies and reconstruction for a CHEK2 mutation, do you need any additional studies, MRIs, mammograms?
Yeah, so at this point, for people who've had prophylactic mastectomies for whatever hereditary cancer syndrome you have, there hasn't been any data saying that you need to continue to get MRIs or mammograms routinely. That being said, I would say that I would have a lot of chest wall or reconstruction self-awareness. If you feel anything new or worrisome, you need to bring it up in between appointments to have evaluated. You know, it is very rare, very, very rare. In my career, which is now where I've been seeing hereditary cancer syndromes for 15, 20 years, I can think of one patient where they did not have a personal history of cancer and they did prophylactic mastectomies and they had a cancer. It doesn't mean it can't happen. We absolutely need to be aware of it. But that is different from someone who's had a breast cancer and could get local recurrences.
Thank you. And another question out there, an oral, I cannot see this.
An
oral subcetabine and recurrence of triple negative breast cancer statistics, if you have any thoughts on that. Sorry, I probably mispronounced that drug name.
Okay, I'm trying to go, what question is that? I'm trying to.
From Barbara.
Oh, capecitabine? Is that?
Yes, that's correct.
Yeah, so there's a lot of data in capecitabine. I don't know that we have it specifically for hereditary breast cancer patients, but in triple negative breast cancer, it's a little bit mixed. So in metastatic cancer, it probably, remember, triple negative breast cancer is not one disease. It's multiple different cancers all lumped together, not by what they are, but by what they are not. And in triple negative, there's a lot of different types. Now, capecitabine tends to not be one that I would go to, especially for a rapidly progressing triple negative breast cancer. It really hasn't been shown to have a lot of benefit in that case. There are some subsets where it can work. And right now in early breast cancer, if you've had preoperative chemotherapy and there's a lot of disease left, we will use it based on one trial. But that trial does have a lot of complications with it as far as who they chose, how they followed, things like that. So, we're kind of stuck with it based on that trial, but there's more trials going on right now trying to sort out who should get that.
Great, thank you so much. And we'll go ahead and transition to our next presenter so we don't go over too much, but thank you so much, Dr. Litton.
Thank you, everyone.
And I'll go ahead and introduce our next presenter, Dr. Ross. And if Dr. Ross, if you would like to go ahead and present your slides, you may. Perfect.
Can you see and hear me okay?
Yes, we can. Thank you, Dr. Ross. And so Dr. Ross is a provider, and he is actually a surgeon scientist who specializes in urology and urologic oncology and is a nationally recognized expert in prostate cancer. His research efforts focus on the development, testing, and implementation of novel diagnostics and therapeutics with a goal of reducing the suffering from prostate cancer. He has published over 100 peer-reviewed journal articles related to the disease and led several clinical trials exploring novel prostate cancer treatments. Clinically, Dr. Ross performs prostate cancer screening, prostate biopsy, including MRI, fusion biopsy, active surveillance, robotic prostatectomy, and ablative therapies of the prostate. Currently, Dr. Ross is an associate professor of urology at Northwestern Feinberg School of Medicine. Prior to joining Feinberg, he served as a director of Johns Hopkins Urology Prostate Cancer Program, executive medical director of the Mary Crowley Cancer Research Center, and an associate chair of the U.S. Oncology Genitourinary Research Committee. We're really excited to have you join us today. Dr. Ross, feel free to take it away.
Thanks so much, and thanks to everyone for your attention today. You'll see that prostate lags a little bit behind breast, so don't be too disappointed that we're still kind of at the rudimentary levels of our genetics. But there's been a lot of progress, and we're moving more and more towards precision medicine in prostate cancer, and have been realizing more extensively the importance of genetics in prostate cancer. So this is just for the patient audience, which I think is probably very well informed. What we're going to talk about is both germline genetics for prostate cancer, which essentially is the genetics of the egg and sperm that you've inherited, and so they're basically in every cell of your body. It can be evaluated in your blood and your saliva, etc. And you, as the patient, could pass them on to your offspring. If you had a mutation, it might also be affecting your other family members. And then we'll also talk about tumor genetics, or somatic genetics, which are mutations that occur in the tumor only, and as the tumor cells divide, can be inherited by the tumor progeny. Mutations in the tumor are, as you'd expect, going to be more likely to occur than just those in the germline by themselves. We can typically test these by evaluating the tumor directly. And newer assays over the last 5 years, I would say, have been fairly reliable at evaluating the circulating free tumor DNA, and we'll talk about that as well. So what we're going to do is we're going to talk about the role of genetics prior to diagnosis. So this would be germline genetics in men, and to see what is their emerging role, for example, in screening for prostate cancer. Then we'll talk about the role of genetics in the management and decisions for localized prostate cancer. And then finally about how we can use genetics of prostate cancer to guide treatment of metastatic disease. So before we talk about screening, I think it's important to understand the complexity of prostate cancer. It's a very prevalent disease. It's the most common non-skin cancer in men. And there's a broad spectrum of prostate cancer. They're both disease that is fairly indolent, and we worry about overdiagnosing that disease, over-treating it, and causing some of the morbidities of treatment, which can be either sexual function, urinary, and sometimes bowel function. But we also know that there's aggressive prostate cancers, and we worry about being too lax with screening and underdiagnosing that disease, undertreating it, and that leading to more cancer deaths, prostate cancer being the second most common cause of cancer death in men. Like I said, there's morbidity of local treatment, and that's problematic, but also in the metastatic setting, we lack curative treatments for prostate cancer. So again, this dilemma of how are we screening? We have the benefit of the prostate-specific antigen blood serum test, or PSA, which really has allowed us to diagnose prostate cancer at a much earlier stage. But because it's not very cancer-specific, we have an issue where in order to actually prevent a death from prostate cancer and make an impact on prostate cancer-specific mortality, we need to invite a lot of men and diagnose a lot of prostate cancer to make a dent in that. So we need techniques to make us better at diagnosing clinically significant prostate cancer and to allow for screening that is going to minimize the overdiagnosis and overtreatment of indolent disease. So it had long been recognized that among the malignancies, prostate cancer had one of the highest inheritable risks. And a lot of previous studies said, well, maybe we could just figure out who's more at risk for developing prostate cancer and intensify screening there. And some of those studies, which were looking at germline genetics and single nucleotide polymorphisms, had found HOXB13 as playing a very significant role in some of the allelic variants in HOXB13 causing a higher propensity for developing prostate cancer. HOXB13 is a homeobox gene. It helps pattern the hindgut during development, and the prostate is part of the hindgut. But those studies are really focused on, who should we be screening more, and not necessarily who had really clinically significant prostate cancer. And so HOXB13 mutations, for example, were a risk factor for development of any type of prostate cancer. And because of the issues with overdiagnosis and overtreatment, I think there's been a little bit of a shift to say, well, why should we don't want to focus on all prostate cancer. We want to look at genetics that might lead us to the diagnosis of clinically significant or lethal prostate cancer. So answer the question of, really who should we screen to find lethal prostate cancers, and maybe even get a foothold using genetics on how we should go about curing those men. And so there was a couple efforts taken. One is to look at sort of like lower penetrance genes that are very associated with prostate cancer specific lethality, and sort of paralleling some of the story in breast. There was a long recognition that some of the DNA damage repair genes that help maintain genomic stability are very important in lethal prostate cancer. Among those, the best evidence is for BRCA2 and its association with lethal prostate cancer. The pie chart there comes from the Stand Up to Cancer efforts, and what they found was among men with metastatic prostate cancer, around 12% had a mutation in a DNA damage repair gene that was present in their germline. Among men with high risk but clinically localized prostate cancer, it was about 6% of those men. And most of those mutations were occurring in BRCA2, ATM, CHEK2, and BRCA1. Also important, they found that these mutations were occurring in many men regardless of a notable family history that the man could recollect of prostate cancer. And so a couple ideas were being born out of this. One, the frequency was a little bit higher than people had thought. And this might affect sort of therapeutic options for those men with aggressive disease. But the second part that came out of it was saying that a lot of these men had unknown family histories. The germline mutation rate is about, in the 10 to 15% range for metastatic men. They may act as sentinels for their other family members for cascade screening. So that if they were diagnosed with metastatic and aggressive prostate cancer, had a germline mutation in BRCA2, for example, we would then tell them this may affect your sons and your daughters in terms of breast, pancreatic, ovarian, and prostate cancer, obviously. So first, how can we take that data with BRCA, 1 and 2, their association with lethal prostate cancer, and take that to the level of saying, well, what should we do about screening? Remember that prostate cancer screening remains a little bit controversial. I think most of us, including the U.S. Preventive Task Force, have backed away from previous recommendations. But at one point, it was a Class D recommendation, and the U.S. Preventive Task Force was saying, don't screen for prostate cancer in a general manner. How about people that we know are carrying genes that are with mutations associated with prostate cancer mortality, like BRCA1 or BRCA2? This was the IMPACT study, which looked at prostate cancer occurrences during systematic screening for men with BRCA2 mutations or BRCA1 mutations versus non-carriers. And it basically showed what we would have expected. The men with BRCA mutations were more likely to have prostate cancer, more likely to be diagnosed at a younger age, more likely to have clinically significant disease. And given this, we basically said that there should be systematic screening for sure for people with BRCA mutations. And that's all well and good, but that's only a small proportion of men that have BRCA1 or 2 mutations. How do we expand that out? And so basically, there's been consortiums like the Practical Consortium, the Prostate Cancer Association group to investigate cancer-associated alterations in the genome that looked at like sort of polygenic multiple SNP signatures. They developed a prostate health score that was based on 54 SNPs that were gauged to or kind of benchmarked for clinically significant prostate cancer, at least intermediate risk disease or up to locally advanced disease being diagnosed. And as you can see on the graphs here in the middle, the top probability of cancer-free survival and the bottom cumulative incidence curves, this prostate health score, now if you look at, say, the 80th percentile and up is where the lines on the bottom, for example, start becoming red, you have a higher age-adjusted risk for developing clinically significant prostate cancer. And as you go into that 80th percentile and more, your age-adjusted risk starts to approach the risk of people with BRCA2 mutations having clinically significant prostate cancer. So maybe you could do a risk stratification, based on these SNPs done earlier in the man's life, and decide who we really need to enforce systematic screening on versus who you don't. There's been other SNP-based polygenic risk scores that have been developed. One by Ambry. Wasn't really benchmarked initially on clinically significant prostate cancer, but it does work to categorize different risks of men developing prostate cancer in their lifetime. And you could use this to stratify who do you need to really have to do screening on, and which men could you perhaps omit routine PSA or prostate cancer screening. The question is this all really relevant? Because whereas before, even just 5 or 10 years ago, prostate cancer screening and PSA-based screening were sort of equivalent, just knowing that PSA was a lower specificity marker but had a high sensitivity. Now that's not really the case. This is the current NCCN guidelines, and the most important thing here is is in the bottom green box, which is that if we have a guy who we think might have prostate cancer because they have an elevated PSA, we're not going straight to biopsy anymore. We want to optimize our ability to detect clinically significant disease and to not detect indolent disease. And we're really moving towards a more specific biomarker or an MRI prior to their diagnostic biopsy. These are one of the biomarkers, a serum-based biomarker, a very cheap and affordable blood test, prostate health index, which you can see in the receiver operating curves to the right, has a much greater accuracy for diagnosis of clinically significant prostate cancer than PSA, which looks at it to be around 50% or point flip level. If you use this simple blood test, then among the men that you've identified with your more sensitive test, but not very specific, meaning PSA alone, you run this test and you can avoid biopsies in about 30% of those men. Similarly, MRI additionally has a high negative predictive value. And if you do MRI in at-risk men, you can avoid biopsies in 30% of those men, and you can have a superior ability to detect clinically significant prostate cancer. And so now, at least on the level 1 evidence, shows that MRI prior to biopsy should be the preferred standard of care for men at risk of prostate cancer development. And so, if we're already reducing the amount of over-detection using these methods, can't we just go back to routine screening for all men, but not biopsy for all men that have PSA elevations? And that's really unclear, but I think that genetics and germline genetics and some of these SNP scores may play a larger, still play a larger role, particularly as they're becoming more cost affordable. And we may be trying to stratify which men should be screened and which one don't need it based on those. But it's going to be a work in progress. How about for men that have already been diagnosed with prostate cancer? Where's genetics helping us there? The role of germline genetics in those men is twofold. One is really to facilitate cascade testing and try to see if other family members might also have these important mutations and thus be at risk for developing other cancers. So right now, the National Comprehensive Cancer Network recommends germline genetic testing in all men with high risk or locally advanced or metastatic prostate cancer, because it's going to be about a 6 to 15% rate of finding an important germline mutation in them. For men with very low risk to unfavorable intermediate clinically localized prostate cancer, if they have a strong family history, there's a recommendation that they have germline testing. That would be one first-degree male relative who had prostate cancer below the age of 60, or more than one relative with breast, ovarian, or pancreatic cancer. There you're thinking about the BRCA genes, or more than one relative with colorectal, gastric, ovarian, or urothelial cancer. There you're thinking about the mismatch repair genes. I think there's a strong argument that we probably should be doing germline genetics on everyone diagnosed with prostate cancer, but particularly with clinically localized disease that we are going to not treat. So with the idea that we don't need to treat all clinically localized prostate cancer anymore, and that for some of the men with favorable risk, at least on the surface, we may be able to monitor them and put them on active surveillance, we may want to know the germline genetics of those men, because even though only a couple % of them will have BRCA 1 or 2 mutations, for example, those that have those mutations tend to progress much more rapidly if put on conservative management instead of electing for immediate treatment. This is data from the Johns Hopkins active surveillance cohort, mostly of very low risk and low risk men. If we look at the bottom right panel B, these are men followed and then looks at their upgrading to unfavorable intermediate risk prostate cancer. So they would move, 2 rungs up in the grade to disease that you really want to cure, and sometimes you need multimodality for cure. If they were in the small percentage, about 1% in this case, that were BRCA2 carriers, then their chance of progression was about 20% even within 2 years. So I think that, like, for the men on surveillance, I would contend that we really want to know if they're in that minority that have germline mutations in their DNA damage repair genes. Maybe we can capture even more men that are progressing. You can see that the blue line is not really 0. Maybe we can catch even more men if we further develop these SNP profiles. But where is genetics for prostate cancer really starting to shine, and prostate cancer really coming into the era of precision medicine? It's really going to be in the metastatic space or in uncurable disease space. Where now we're really kind of trying to strongly push for both somatic and germline genetic testing for men with incurable prostate cancer. And that's because it might help influence our choices for androgen receptor signaling inhibitors versus taxanes. It might help us with second-line choice of therapy for PARP inhibitors. And recently we've had FDA approval of olaparib and rucaparib for prostate cancer. It might help us understand mechanisms of disease resistance as you progress through lines of therapy. Obviously, for all cancers, not just prostate cancer, there's now the increased availability of immunotherapies, with both PD-1 inhibition being approved both for microsatellite unstable MMR mutated tumors and now for tumor mutational burden high tumors. There may be some evidence with some other neoantigen producing mutations like CDK12. And a lot of clinical trials are ongoing right now looking at things like PI3 kinase inhibitors or AKT inhibitors. So let's look at that more closely. For incurable prostate cancer, for a long time, from the 40s almost to about 5 years or 10 years ago, the standard of care kind remained somewhat static. Basically, from data from Dr. Huggins and others showing that prostate cancer was androgen addicted, and if you did hormonal suppression of prostate cancer using androgen deprivation therapy, you could increase their survival, keep the disease at bay. And this was mostly done with LHRH agonists or antagonists that would basically shut off the hypothalamus, telling the pituitary, telling the testes to produce testosterone, or with androgen receptor blockers, the first and second generation blockers like bicalutamide. There was the realization that most prostate cancer would progress after a couple of years or within a couple of years from a hormone sensitive status to a castrate-resistant prostate cancer status, and then therapies were developed, to kind of continue treatment after that period. But when people looked at the genetics of tumors and the ways that tumors were progressing, it appeared that the tumors were mostly progressing by figuring out how to use the small amount of androgens that were still available to the body. And so we started to think, well, what if we intensified therapy up front for newly diagnosed metastatic prostate cancer, either using a chemotherapy that seemed to work in prostate cancer, which was docetaxel, or by using better, more potent androgen signaling inhibition. This was data for upfront using chemotherapy with docetaxel as well as LHRH agonists for prostate cancer. And what they saw was in the high volume disease, you could increase the overall survival by adding on docetaxel in the hormone sensitive space. This looked at intensifying your androgen inhibition by using molecules that would be CYP17 inhibitors and inhibit the production not just from the testes, but the adrenals and maybe intratumoral testosterone. And this type of androgen signaling inhibition, also if you intensified on top of your normal chemical castration, would increase overall survival. And this finally is data with apalutamide and enzalutamide, which are like sort of third generation androgen receptor blockers, also showing that you can increase overall survival by intensifying therapy early for hormone-sensitive prostate cancer. So now the standard of care is now to intensify therapy early for hormone-sensitive prostate cancer. But what should we do it with? Should we do it with chemotherapy? Should we do it with hormonal agents that are more blocking the androgen signaling cascades? What we know is that the androgen deprivation therapy and androgen signaling molecules seem to affect genomic stability as well, and there was some thought that they may synergize with DNA damage repair deficient tumors. And maybe this is some peripheral evidence of this. This is the Pro-Repair B study that showed that people who had DNA damage repair mutations, if they got an androgen signaling inhibitor up front, like enzalutamide, abiraterone, apalutamide, they tended to do almost as good as patients that had metastatic prostate cancer and did not have a DNA damage repair mutation. But if you gave them chemotherapy with taxanes, that's the solid red line, then they did much worse. So maybe it informs that decision. But how about an actual, precision medicine decision, as we saw with breast, using PARP inhibitors? We got a lot of this from the last lecture, but essentially, PARP is involved in DNA repair pathways. And usually when there's damage, a single strand, break in the DNA, it can be repaired by base excision repair and other mechanisms that somewhat involve PARP. But there's a backup mechanism as well of homologous recombination if you need it. If you inhibit PARP or there's some problem with the base excision repair pathway, say you use olaparib to inhibit PARP, there'll be a double strand break in the DNA, and sometimes you can still repair it by non-homologous end joining, but that's sort of muted. More so, you're going to rely on homologous recombination to repair those breaks. If your tumor was homologous recombination deficient, say it had a BRCA mutation, and now you also inhibit the PARP pathway, you kind of have taken two legs off of the stool of DNA repair, and this can result in catastrophic genomic instability, leading to cell death. So in breast cancer, ovarian cancer, and recent data in pancreatic cancer, PARP inhibitors could be effective if you have DNA damage repair deficiency. And, this is the profound study shown to the right, which looked at the olaparib in two cohorts of patients with this DNA damage repair deficiency to say, would it improve the survival for men with castrate-resistant prostate cancer progressing through therapy? In cohort A were men with BRCA1, 2, and ATM mutations. Cohort B, which I didn't show here, had any of the mutations in the other DNA damage repair response genes. And what you saw was an improvement in overall progression-free survival if you use cohort A and B, which is what the study was powered for. If you looked at, particularly at cohort A, you saw a more dramatic improvement in progression-free survival. And if you looked at cohort A, you saw an improvement in overall survival as well. And this led to in May, to the FDA approval of olaparib for castrate-resistant prostate cancer progressing through previous therapy with any DDR mutation that you could get a PARP inhibitor. As you can see on the forest plots to the bottom left, BRCA2 is really leading the charge and having the best response to PARP inhibitors, with less significant or sometimes no responses among some of the other identified DNA damage response genes. Now, I would say that cohort B in this was somewhat underpowered to really make any firm assumptions on who's going to respond and who's not going to respond. And whereas in this phase 3 study, some of the mutations didn't really seem to affect PARP inhibitors like ATM, which has a hazard ratio of 1. In the 2-PARP study, which was the phase 2, there were people with ATM mutations that did respond well to PARP inhibitors. And so how do you reconcile that data? I think, as was mentioned in the last talk, in my opinion, you might want to see a downstream effect of deficiencies in these DNA damage repair pathways leading to deficiencies in homologous recombination. I think the way to look at that is the way it's been looked at in ovarian cancer, with something for like the homologous recombination deficiency status. And so you can look, if you have germline and somatic sequencing of your tumors, which is the way I tend to do my somatic testing, is I'll send germline as well. Then you can start looking at loss of heterozygosity, and people with higher loss of heterozygosity might be the ones among these mutations that will respond better to PARP inhibitors, but that has still to be studied in prostate cancer. This is the FDA approval, the study that led to the FDA approval of rucaparib. It actually was approved based on a phase 2 study. This is the Triton 2 study. Triton 3 is ongoing, which I think is it was nice for me to see, because it meant that the FDA is sort of being more permissive with understanding that a lot of these precision medicine drugs, when matched to their identifiable targets, are going to make a big impact. This study just looked at BRCA1 and 2 patients, and you can see the PSA responses, which are indicative of or match the tumor responses in many cases, and lots of patients with BRCA2 or 1 alterations responding to the therapy. How else can we use tumor genetics to make our clinical decision makings in prostate cancer? Prostate cancer tends to metastasize to lymph nodes in the bones. Sometimes when it progresses, it's in the bone-only status. And so we sometimes don't have the ability to do tumor somatic genetics. And it's also, there's some arguments that the tumor somatic genetics of what you biopsied is just the genetics of what you biopsied, and that there's heterogeneity among tumors, particularly different tumors in different metastatic areas. So how do we look at all the tumor genetics as a conglomerate? Maybe we should be looking at circulating tumor DNA. This is DNA that's shed off of tumor cells, either circulating free or sometimes in exomes. And I think in the last 5 years, and particularly in the last 3, I've had a lot of confidence in the calls of circulating free tumor DNA. It's less, maybe less robust platforms, obviously, than doing it from the tissue, but it does give you a good signal in many cases. And for prostate cancer, because we're using a lot of agents that are targeting the androgen receptor, you can sometimes pick up mutations in the androgen receptor that are going to change your agent from an antagonist into an agonist, and those can be very important. Finally, and I think you've heard a lot about this from previous talks, checkpoint blockade is probably one of the largest advances we've had in cancer therapeutics, and particularly in immune oncology. Normally, you're doing your T cells and other immune effectors are doing a sort of a full surveillance of your body. They're they're wired so that if the T cell recognizes a cell in your body that sort of looks like you, then the default is to say, well, I'm not going to kill that cell. It looks too much like the host. And so instead, I'm going to commit cell suicide or programmed cell death, or I'll go into anergy. I'm not going to cause any type of autoimmune reaction. Checkpoint blockade is saying, no, wait a minute. We want to take the brakes off a little bit. We know that this patient has cancer of some type. If you have a question mark about, is this cell really host or is it foreign? We want you to lean towards saying it's foreign. It's sort of like host, but it's a tumor. Go ahead and do your T cell effector functions and destroy that cell. Which tumors are going to be more recognized by your T cells? It's ones that are as foreign. It's ones that are making more neoantigens. And who's making more neoantigens? It's ones that are mismatch repair deficient or have more microsatellite instability. In prostate cancer, that's about 2 to 3% of the patients, generously 2 to 3%. Or another product would be patients with higher tumor mutational burdens. And the FDA had the first tumor agnostic approval with pembrolizumab, which is an anti-PD-1 therapy for mismatch repair deficient or microsatellite unstable tumors. And then that went on to more recently approval for it for high tumor mutational burdens. And this is endorsed by the NCCN guidelines for prostate cancers that are progressing through therapies as well. There's been more recent evidence emerging with other things that can make tumors immunogenic. There was a nice study with CDK12 biallelic loss showing that it can make extensive tandem duplications, and those could lead to more neoantigens and maybe some responses to checkpoint blockade. It's still a developing story. This is a small phase 2 showing that really the minority of patients have a really good response to checkpoint inhibition when they have CDK12 deficiencies. But regardless, I'm happy as a prostate cancer treating urologist and physician to see that genetics is finally coming strongly into our field. We see that tumor and germline genetics can have important impacts in both the diagnosis and management of our prostate cancer. Germline genetics can maybe help risk stratify patients for screening. I think our screening has become more sophisticated in general, and so the real impact there is questionable, but there's still problems with national adoption and international adoption of prostate cancer screening, and perhaps using germline genetics, polygenic risk scores, and SNPs will at least identify if we want to conserve resources, which populations we really have to intensely screen. The second thing is that germline genetics for people who have been diagnosed with aggressive prostate cancer are important because the family history is often lacking in some of these, or maybe not sufficient. And we want to really do cascade testing to identify who in the population is going to be at risk for not only prostate but other important cancers. And then finally, as I sort of showed towards the end of the talk, the somatic and germline genetics are going to alter therapeutic choice. PARP inhibitors, as of May, are now approved in prostate cancer and standard of care for castrate-resistant prostate cancer progressing through therapies, both olaparib and rucaparib. We're also seeing that the genetics can look at mechanisms of resistance that can be uncovered in some rare cases, but I think a clinically significant proportion. You could use immunotherapies at progression. And finally, there's many ongoing clinical trials that are matched to tumor genetics in prostate cancer, as there is in the bigger spectrum of all cancers. Thanks so much for the opportunity to present. I don't know if we have a few minutes. I tried to rush through a little bit to kind of catch us up, but if we have any questions, I'll be happy to take them.
Thank you so much, Dr. Ross, for your presentation. I think at this point in time, we're going to move towards our gene breakout sessions just for the sake of time. So for anyone that does have questions, you may want to bring these up in your gene breakout session. While you guys have been listening to these other presentations, I've been working to assign you to your gene breakouts. So I'm going to go here in a moment and open those. For anyone that does not move into a breakout room, it's probably because I wasn't able to figure out which room you were supposed to go into. So I'll work at that point in time to try and get you over to the correct room. Just as a reminder to everyone, it has been in the chat throughout the presentation, but there is a feedback survey. You only need to complete it once, but if you could complete this feedback survey, we really appreciate that information so that we can continue to improve this conference. I can see Kelsey just put it in the chat. And when you do complete it, there'll be an option to enter your email address, and that will enter you into a drawing for some electronic gift cards. We'll pull those winners in about a week time after the survey closes, and we'll email any of those people that won their gift card, likely Amazon or Target. So with that, I'm going to go ahead and open the breakout rooms. Once the breakout rooms are over, it'll bring everyone back to the main room, just kind of for our final goodbye. But let's go ahead and get these open.